Hello, good morning, everyone. I welcome you all to the second day of Convergence 2022, International Conference on Allied Health Sciences, organized by Vijaya Educational Academy in association with Society for Nursing Practices, an academic partner of Vijaya College of Nursing. I'm sure you had a great day yesterday with us, and I really hope to see the same enthusiasm from all of our presenters and attendees today. So moving ahead, I would like to welcome all our honorable dignitaries and eminent keynote speakers. So we will be starting with today's conference event. So for that, I would like to welcome our first keynote speaker, Dr. Shobha Gangadharan. She is an associate professor, College of Health Sciences, University of Buraimi, Oman. So she pursued her education in Tamil Nadu, completing her bachelor's degree in nursing from June 1991 till April 1995, along with her PhD in nursing from Dr. MGR Medical University, Chennai. She is currently working as an associate professor in College of Health Sciences, University of Buraimi, Oman from February 2022. She has also worked as associate professor of nursing in King Khalid University from November 2019 till August 2021, Khamis Mushayed Asir, Saudi Arabia. She also served as professor and departmental professor and head of Department of Community Health Nursing from April 2010 till October 2019 in Apollo College of Nursing, Chennai, India. We really welcome you, ma'am. We're really happy to have you as on board. Dr. Shobha Gangadharan, ma'am, are you there with us? Dr. Shobha Gangadharan, ma'am, are you there with us? I'm sorry for the technical delay. Dr. Shobha Gangadharan will be joining with us shortly. She's facing some technical issues.
कहाँबाट सेयर गर्नु
आफ्नो आफ्नो त यहाँ सेयर स्क्रिनबाट हो हैन यो सेयर
Hello, everyone. I'm sorry for the technical issues that we are facing for now. So again, I would like to welcome you all for the second day of Convergence 2022 International Conference on Allied Health Sciences organized by Vijaya Educational Academy in association with Society for Nursing Practices and academic partner of Vijaya College of Nursing. We'll be starting with today's program. So for that, I would like to call Dr. Shobha Gangadharan, our first keynote speaker. She's an associate professor, College of Health Sciences, University of Bahrain, Oman. She pursued her education in Tamil Nadu, completing her bachelor's degree in nursing from June 1991 till April 1995, along with her PhD in nursing from Dr. MGI Medical University, Chennai. She is currently working as an associate professor in College of Health Sciences, University of Bahrain, Oman from February 2022. She has also worked as associate professor of nursing in King Khalid University from November 2019 till August 2021, Khamis Mushayed Asir, Saudi Arabia. She also served as professor and departmental professor and the head of Department of Community Health Nursing from April 2010 till October 2019 in Apollo College of Nursing, Chennai, India. We welcome you, ma'am, with us.
Good morning, everyone.
Good morning, ma'am.
My video is not showing here. It cannot, I think it's showing you cannot start your video because the host has stopped it. Can you make it accessible?
Sure, ma'am. We are working on it.
Thank you.
You are visible, ma'am.
Yeah, thank you. Very happy morning again to everyone who's present for this conference, the second day of the conference. And I am happy to share my screen and to talk on this keynote address on this special topic about stress management for allied health sciences and the healthcare workers. And this is my, although I am in another country, I am talking to my home country and especially to my hometown people. I'm very happy about that. Just a moment, I'll share my screen. My screen sharing has to be enabled, showing host disabled participants sharing screen. Yeah, now my screen can be shared, right?
Yes, ma'am.
Yes. Okay. So the topic is stress management and coping strategies for healthcare and allied health sciences. We all know the impact of stress on the general population and more specifically on the healthcare workers, because healthcare workers are the one who's round the clock working with the patients, and they undergo a lot of stress when they are dealing with the patients. They especially come across a set of variety of challenges. Unlike many of our friends and family members, we were unable to work from home even during the pandemic. So when we continued working in the hospitals during this pandemic situation, again, there were different kinds of stress. I have heard many people saying, many young nurses and other healthcare professionals saying even their children were not given play school admissions because they are healthcare professionals. And they have to literally keep the children at home or directly send them to the school, things like that. We are in the front line serving patients that need our assistance. We are challenged with additional stressors due to this. And this ongoing stress and trauma, it impacts mental health, safety, and ability to provide the best possible care. So as a nurse, we have to provide the best possible care, or as a healthcare professional. But when we have to provide this care, we need to be healthy physically and mentally. When the mental health affects, the physical health also gets affected, vice versa. Taking steps to manage your stress is just as important as taking care of our physical health. But most of the time when a physical health issue comes, we take care, we give importance to that. We go immediately to a doctor, whether inside the hospital or outside the hospital also. But when it's mental health issue, most of the time people procrastinate, that is, they delay it. Now, what is stress? Stress is a normal reaction to everyday pressures, but can become unhealthy when it upsets your day-to-day functioning. See, normal, it is a normal reaction for a daily pressure what we are undergoing. But if it is going to be consistent over a period of time, then it is going to affect our health, or it's going to affect our day-to-day functioning. This definition is given by APA, American Psychological Association. Okay. We just saw the definition of American Psychological Association, but there is no one definition of stress that everyone agrees on. What is stressful for a person may be pleasurable for another person. Say, for example, you take a roller coaster ride, maybe it's enjoyable moment for some people, but the same roller coaster ride could be a stressful event for another person. So it varies. So we all react to stress differently. So stress is a gap between our expectation and reality. The more the gap, more the stress. So expect nothing and accept everything. So it doesn't mean that you have to accept everything, whatever another person says. But better if we don't expect much and accept as it comes, and then react to it. React to it in the sense, when we accept, we should accept it, and then as and when needed, we'll have to react to it. Now, how the stress is going to affect ourselves? as a healthcare professional. It can affect our body, it can affect our mind, emotions, and behavior too. So what happens? See, when it affects the body, it can cause skin problems, headache, fatigue, frequent illness. Sometimes people even forget to drink a glass of water when they are stressed, or they forget to have their food. Mind, how does it affect the mind? The focus gets lost. They get nightmares, negativity, constant worrying, loss of confidence. With regard to emotion, it can cause loss of confidence, depression, anxiety, apathy, all those. What happens with the behavior? So the person, imagine they start smoking, because they think I'm stressed, I have to get into some behavior. It's not a conscious behavior, but without their knowledge, sometimes they get into smoking or indulging in any other behaviors. Insomnia could be there, loss of appetite, low libido could be there. Okay, there is different levels of stress. It could be from low to moderate to high. It's like any other speedometer, we have a stress meter also. Now, there are two kinds of stress. One is constructive stress and another one is destructive stress. What is constructive stress? It acts in a positive manner for both the individual and the organization. So both of them get benefited when it's a constructive stress. Say, for example, you have a meeting tomorrow. So you're preparing for the meeting. So definitely you will have a constructive stress. So you behave, you act in a positive manner, and both get benefited, the individual and the organization. Here indicates a situation where the individual is in balance or within the tolerable limits. So when there is constructive stress, there is balance, and they are able to tolerate it, they are able to manage it. Whereas in destructive stress, it is not healthy for both the individual and the organization. Indicates effects that are out of balance. So there is no control, and the person is not able to tolerate. There is no, it's away from the tolerance limit of the individual. Now, optimum level of stress. What do I mean by optimum level of stress? The important key is to find out an appropriate amount of stress for the organization in general and for each individual particular. So we will have to find out what is the level of stress, the amount of stress which is tolerable or within the limits for the organization. The heads will have to find out, okay, this more than this we should not put the person under difficulty, the nurses or the healthcare professionals. Okay, this should be the limit. Okay, for example, uncertainty can lead to stress. Okay, all on a sudden, if it is a planned event, fine, you understand. But all on a sudden, unplanned, all on a sudden they call you for a duty, maybe in the late night, it gives you a stress. And it is not just uncertainty can lead to distress. So can certainty or over control also can lead to stress. Sometimes always it is expected. You know that they are expecting, but always people, when people every time they expect only from you, it becomes a burden for the person, right? Performance evaluation can lead to distress, but so can lack of feedback regarding the efforts. See, you know, every institution or organization has got performance evaluation at the end of an annual year or so. So when that can lead to a stress, at the same time, when they evaluated and when they have not given you a feedback, that also maybe you have put a lot of efforts, you have put a lot of hard work, but then you didn't get good feedback or a feedback at all. So that can also cause stress. So either way can cause stress. What is it? Stressors are the things that can cause stress. What can cause stress is stressors. So they influence the work, attitude, and behavior. So when these stressors play a role in your work environment, that changes your work attitude and work behavior. During your work, your attitude changes, your behavior changes because of these stressors. It is important for the managers to understand and recognize stressors. So the managers have to timely understand and recognize the stressors because they are job-related stress. So it is not for the healthcare professionals. They don't. It is not the stress they have carried from home. Of course, they may have some stress, but those stressors they will be able to balance to most of the extent. But if it is job-related stress, the managers or the immediate boss have to recognize it and intervene accordingly. What are the major sources of stress? We are going to see one by one. First is occupational demands. Some jobs are more stressful than others. Say, for example, higher level jobs contain high amount of inbuilt stress in form of time pressures. Yes, it is time bound. They say deadlines are there. You have to finish this within this particular time. Say nowadays, the corporate hospitals, they have deadlines. They have, they have to achieve this many, even doctors have to achieve this many surgeries have to be done in a month, in a week, or this many patients they have to see, things like that. Too many meetings, difficulties in meeting the standards, interpersonal games, all those can cause stress for even the boss or the higher level people. So you may think only you have stress. Maybe the newly joined or novice healthcare professionals, but it is not so. Everyone at every level have got stress. Lower level jobs can contain stress producing situations that emerge on technical grounds or role frustration. So at the lower level, maybe when you are new, it could be at technical grounds or low, which can be role frustrations. Maybe the given role you are not able to adjust or adapt to this role, that may be causing frustration. The more interdependence between a person's task and the task of others, the more potential stress there is. Moving on to the next point, that is role conflict. A role is a general set of guidelines indicating how persons holding certain positions should or ought to behave. So a person in a particular position, they are expected to behave in a particular manner. So, but in that case, the person may have some role conflict. Maybe they have taken up a new role, new position, and they are expected to behave all on a sudden in a different way, which can cause some difficulties for them. So here the types of role conflict would be intra-center role conflict. Intra-center is always within the individual. Okay, the conflict is between the individual gets conflict within themselves. Am I doing the correct thing to my role? They are trying to do during the process of trying to do it, they may have some conflicts. Inter-sender is this person is sending an information to another person. During the time, there could be some conflict between the sender and the receiver. Inter-role, between two roles. Okay, you may be a boss today, or you may be a boss for another person. Maybe who was working under you, and may also have to report to your higher authorities. In that case, there could be inter-role conflict. Then there is person-role conflict. So the person is there, and for him, they have conflict within their role also. Moving on to role ambiguity. What is role ambiguity? It occurs when position holders are uncertain about limits of their authority and that of others, or company rules, job security, and the methods used to evaluate their work. So those who are holding a position, they don't know their limits. Okay, so say for example, the person is a leader, a nurse leader, or a head of a particular department, but they also have limits in their authority. But what happens is, without knowing their limits, if they keep acting or bossing over others, that can have an impact, uneventful impact on others too. It is related to low job satisfaction and to feeling of job-related threats. Maybe the person is feeling a threat within themselves. Imagine a person has joined newly to an institution. The person who has joined newly is a senior person, but already there is a person who is working in that hospital who is a junior in age, but this person is there for many years in that institution. The person who is already there is supposed to orient the newcomer who is a senior person. This already the person has a role ambiguity. The person thinks the other person who's coming as a threat. So the person acts differently. So which is going to affect both of them, both of their mental well-being. Role overload. Persons who experience this condition show clear signs of stress and report health problems. So when the person has overload of work or responsibility, then they will definitely exhibit the symptoms of stress, and this is going to cause more health problem for the individual. Now, there's something called role under role also, as we saw role over. Having nothing to do. Sometimes when a person who was working always, when they don't have nothing to do or being asked to do very little in one's work, then it is going to cause stress. Imagine the person is potential and the person has not rested like that at all in any of the places where they have worked. All of a sudden, they are not given the responsibilities. Then they undergo stress. This could lead to low self-esteem, increased frequency of nervous symptoms and compliance, increased health problems. The person feels, oh, I am not given recognition, I am not given importance, and then that's how the person has his self-esteem goes down. Moving on to personal relationships. Poor interpersonal relationships in organization results in stress. Okay, so within the organization, there should be good interpersonal relationship between the individuals at every level. So that will, open communication will help in better relationship. So 3 aspects of job stress which have negative influence are amount of contact with others. You wanted to say something to your fellow co-worker, but you are not able to say. That could be a problem. Amount of contact with people in other departments. It should not be too much or too less. It should be appropriate. And the climate of the organization also is very important. How is the organization's climate? That is also very important. Should be conducive. Yes, whole health begins with mental health. So just not being physically healthy is not health, mentally healthy also. When we are all healthcare professionals, and when it comes to us, when the stress comes to us, we do get affected. Yes. So who has to help you? You cannot expect help from anybody unless you open up your problems or issues. So first of all, you have to reduce your stress levels and get support, and get support from your fellow colleagues. Okay, so and your role is also, if another person of your friend is undergoing a stress, you have to identify it and support them. That would be the best way. Supporting each other would be the best way, and that would be more helpful too. Now, stress management for healthcare professionals usually aren't much different from others. So it is the same actually. Stress management for others and for healthcare professionals, it is the same. Since stress in the medical field is widespread, it's even more essential that healthcare workers know the signs of stress and solutions for managing it as well. So you as a healthcare professional, maybe a student, maybe a already working healthcare professional. See, student nurses or the student allied health professionals also undergo stress, because unlike another profession where they are not into the field, maybe they go for some visit or something, that's their exposure into the field. But our students in healthcare, they are into the field as they are students itself. So then they don't know the expectation versus reality comes there. They are really stressed. Am I to intervene now or not? What should I do now? So many questions will be there within them. It is the responsibility of the immediate boss or the instructors to help them manage or cope with the situations. Why is mental health important for health workers? Many things go hand in hand with poor mental health. Say, for example, your sleep gets affected, your concentration goes down, and your ability to handle stressful situation gets affected. Poor mental health can affect all areas of lives, not just our working ability. It impacts how we act. When someone comes and talks to us or deals with us professionally, when you are under stress, you cannot deal with them anymore. Whether it is patient care, whether it is communication with your professional colleagues, also it can affect. And your feelings also get affected. When you provide high quality care, it requires a good level of focus, quick response, and empathy. And all of this are hard to achieve when experiencing poor mental health. So if you have to provide a good quality care, you need to have a good focus, respond quickly, and also you need to empathize with the patients. So for which you have to be mentally healthy. Taking care of workers' mental health is very important. So this is the role of the boss or the immediate supervisors. The staff present are able to work. They should see that the staff present, they are able to work to the best of their ability. Working in an emotionally charged environment, that is going to tax the individual. Okay, so every time there is some stress undergoing, already it's a hospital or a healthcare industry where there could be emergencies, public health emergency. You could have had many public health emergencies during pandemic, and already when all those are undergoing, you are going through. But imagine the environment in the hospital is going to be emotionally charged, and it is going to affect a lot. Okay, so offering emotional support to others is going to be difficult. When you are not healthy, you have to be emotionally good, so that you can offer support or help to your colleague or another person. We often hear that you can't pour from an empty cup. Is that true? Yes. When you are trained mostly, how can you help another person or a patient? Now, both the things cannot happen. This is very fitting for health and social sector where workers are required to give so much. So as healthcare professionals, we are required to give so much. So when we are required to give, we have to keep up our health. That's very important. Our physical health and mental health. So definitely it is not going to be the same for a person who's with the family, non-medical person and a medical professional. It's going to be different. The common symptoms, see, when we will go into a disorder called post-traumatic stress disorder. What is this post-traumatic stress disorder? Stress is undergone by most of the healthcare professionals, and sometimes when we witness maybe a patient dying or patient receiving CPR, maybe especially new nurses or newly appointed healthcare professionals, they may undergo this post-traumatic stress disorder. Not necessarily new people, those who are consistently in intensive care units, they can also undergo. See, that is why they say you have to change them periodically, otherwise they may be under PTSD. So the symptoms of PTSD is nightmares and flashbacks of the event. It comes to your mind always, what happened in your workplace. Feelings of isolation, a tendency to withdraw, irritable mood, feelings of guilt. Say, for example, you tried your level best to save a patient, but you couldn't save. Then you may have a feeling of guilt. So there's nothing to worry. If you have tried your best, you have tried hard, You are not able to. That's not a big thing. You have to let go. Let go is very important mantra. Difficulty in concentration. Yeah, again, they will have difficulty in concentration, sleep problems like insomnia. Okay, in PTSD, how a person reacts at the time and following the event will depend on many factors. There is no right or wrong way to feel. Many healthcare workers will expect to witness traumatic events on a regular basis. As I told you earlier, most of them are regularly witnessing traumatic events in the hospital. So they need some they have to keep themselves feel better. They have to start some recreation, things like that. Still, the healthcare industry have to work on it. Say, for example, IT industry, the technical people, they understand they need some relaxation, but the medical industry needs more relaxation or recreation or a change in the duty from a critical care unit to another unit, things like that. It is important to remember that the first time witnessing an event such as a patient die, seeing relatives grieving, being involved in or witnessing CPR, I told you all this. Most common causes of stress in healthcare workers, what are they? One is, imagine many staff were on leave. Then this could have happened during the pandemic. When the pandemic was in the peak, maybe some staff also had COVID and they were on leave. Then the hospital goes understaffed, and that could be a critical situation. Some will be working for long hours, things like that. Lack of resources. You have to give care, but you don't have adequate resources. Challenging patients and relatives. Sometimes some patients may be asking you a lot of questions, which you don't have an answer for that. Sometimes you may have challenging relatives of the patients also. A lack of sufficient training or skills. Yes, if you are in a unit, but you are not trained for that, or you don't possess the skills, then it is difficult because there is less staffing there. They put you there, and if you don't have adequate skills, then it's going to be again difficult for you. You may cope up after a few days or weeks, but then till then it is going to be difficult. So there are now a lot of online courses you can take up. Very health related online courses are there, like Coursera, Johns Hopkins University, they're all giving. Shift patterns can cause stress, heavy workloads, long shift hours, unsociable hours. Yes, you are not able to socialize at all. You are there for 8 hours, 10 hours in the hospital, but all the hours are unsociable, means then it would be very difficult. The other side, patients or the people are under isolation in pandemic, but whereas the healthcare workers, they are also in the hospital, but not with this unsociable hours, things like that. Poor working relationship, dealing with death, all these can cause stress among health workers. Stress can cause the following. What all it can cause? Feelings of fear, anger, sadness, worry, numbness or frustration, changes in appetite. Your hunger may either increase. Sometimes people say, no, stress eating. People can sit in front of the television and keep eating a lot. Energy levels either may be more sometimes, or sometimes they may go sit alone and they may keep sitting or lying down. They don't respond to anything. Desires, your interest may go down, desires may go down. Difficulty concentrating and making decision. So during stress, it is not that easy to make decisions. Though the person may be a good decision maker, stress and the uneventful situation may affect them. Difficulty getting sleep, and when they get sleep also, with what thoughts they had gone into sleep can cause nightmares. Physical reactions such as I already discussed this, headache, body pains, stomach problems could be there. GI symptoms always are stress related. and skin rashes. Sometimes there could be breathing related problems also in stress. Even a person can get asthma in stress. Worsening of chronic health problems, yes, asthma. Imagine they are mildly asthmatic, it can worsen. And chronic health problems like diabetes or hypertension can also get worsened. Worsening of mental health conditions, yes, when the stress can also help make the person get indulged in alcohol, tobacco, and other substances. Yes, what to say? Literature says during pandemic, many of the adolescents have got involved in. The percentage was more compared to before pandemic times. Tobacco use and alcohol and other substances, people started indulging in it. Then impact of work-related stress. So when it is work-related stress, what are the impacts? Psychosocial, psychological responses like mood is low motivation, exhaustion, anxiety, depression, burnout, and suicidal thoughts could be there. And physical reactions could be the person could have some digestive problems, skin problems, dermatological reactions, psoriasis, all those can get aggravated. Cardiovascular disease, musculoskeletal disorder, headaches, and unexplained aches and pains could be there. It could be like psychosomatic. Increased risk of work injuries and accidents due to reduced accuracy. Yes, I told you already, there could be less focus or concentration during stress. And this can cause injuries in work, and there could be, it could be worsening also. Impact on workplace productivity. Say, for example, the person goes absent. So increased absenteeism and presenteeism both can cause problem. See, presenteeism, how it can cause, you may think. Most of the time in India, presenteeism was given more importance. But I would say if a person is unwell, they should be given leave and they should be given a break from the work. That would give lot of difference. When many of the other countries are looking upon it, even we'll have to look upon it in India. Of course, there is understaffing, all those things in India. We will have to look upon when we need quality, when we expect quality from the healthcare professions, we'll have to look upon both this absenteeism and presenteeism. Lower job engagement and reduced job performance with respect to both quality and quantity of work. Stigmatization. What happened is during COVID-19. Okay, due to stigmatization and social rejection regarding the quarantine barrier in form of discrimination, suspicion, and avoidance by neighborhood. Yes, many healthcare professionals faced this when they were during the pandemic. When they lived even in apartments, the neighborhood were all showing faces, they were showing differences on them that affected again their emotions and mental health. Workplace prejudice. Yeah, in the workplace, what happens is maybe the leader or the supervisors, if they show prejudice, that is going to affect the individual. And withdrawal from social events even after containment. So even after you are fit to work, if you are withdrawn from social events, again that is going to affect. So withdrawal from social event is there. It was there for almost years now, for the past 2 years or no, for many people. So recently, when people started attending social events, they were really happy. Even adults were like children when they started attending social events, like even a small going and watching a movie. I think I recently watched a movie here after 2 or more than 2 years, right? So it was very just for we were thinking whether it will happen or not in this COVID times. Healthcare workers involved in COVID patient care were found to be more prone to stigmatization. Yes, we all know that. Now, coming to stress relief tips for healthcare workers. So there are 4 tips. One is pinpoint the cause, discover stress busters, ask for help, and talk it out. Pinpoint the cause. If you are a health worker who is experiencing workplace stress, your job, what is the one which is causing you stress? The job. Your job is the one which is causing the stress. Identify it. So pinpoint the cause. When you understand this is the cause, for anything, for any health issue, when we understand the cause and when we try to remove the cause, things will be all right. So try to understand what is the cause. If you feel you can find the solution easily. So identifying the cause, once you know the cause, you can begin to think about the changes to make in your work life. For example, if you find you're overwhelmed, maybe you are working more because you have a heavy patient load, try to speak to the supervisor. Maybe we may think on our own that my supervisor will not understand me. No, why don't you try? Give a try talking to them. It works sometimes. Okay, ask them an appointment. Ask them to spare a few minutes with you. Can I have a talk with you for 2 or 3 minutes? I would like to clarify or share with you something. Okay, so in a manner which they can understand, you can explain to them. Second one is discover stress busters. Each healthcare professional stress management routine differs. Yes. See, the one which works for one person may not work for the other. Okay. So find out what works best for you. If more conventional activities like exercise or meditation work for you, that is the best. Say, though it is conventional, maybe you learned yoga or meditation and that gives you peace, it may work for you, fine, you can go ahead. But if it doesn't work for you, there are definitely other ways for stress relief. Yes, they are very easy and very simple, but we might have not practiced it sometimes. Singing or dancing, both these are fun ways to let off some steam and be a little silly. You don't need to know how to dance. If you have to dance within 4 walls, inside your bedroom or inside your room, yes, you can just dance or you can sing, whatever. Practice a song by yourself and do that. That would also help. Music. They say listening to a music will lift your moods and can also remind us of good memories. Listening to music like Celtic music, you will get in YouTube a lot of Celtic musics or stringed Indian musics. What are the stringed Indian musics? Any of your string musics like violin, veena, our traditional veena, all those are stringed Indian musics. They can all significantly reduce stress. This is from the foreign journal, what I have taken, but they have mentioned about stringed Indian music. Self-expression, expressing emotion is a way to get things off, but you don't have to visit a therapist. See, always to express, I need a therapist. No, nowadays, therapist culture has come. It's good. Older days, it was all, even a big mental health issue is there in the house. Due to stigma, they were hiding. But nowadays, the present day youngsters, they are ready to approach mental health professionals or a therapist. So just by expressing emotion, you don't need to go to a therapist. You can do laughter or crying, both can be cathartic. Say, for example, you can watch a cartoon movie. A Tom and Jerry can help you burst out with laughter, and that can be also a catharsis for you. Acts of self-care. Indulge in some hobbies which helps you relax and give you some give some space for yourself. Though you may have very many activities after your work, saying no for certain things is very important because you need to take care of yourself. Maybe a craft, if you know knitting, you can go do knitting, getting a massage in a parlor, or going to movies, as I said before. All these are acts of self-care. Okay, if you like taking up a swimming class, you can go for that. Definitely swimming helps a lot. And there's no age for learning swimming. See, any learning, there is no age for learning. Only thing, your passion matters and your perseverance or effort matters. Ask for help. Definitely, you will have to ask for help. Establish your limits and know how to stay within them. If you find your responsibilities at work seem to be more than you can handle, please ask for help. You can request your supervisor to help lighten your workload. Give me some light workload for a while, and then later I will definitely take up the same old unit, something. All those you can tell. Ask your spouse at home. If you're married at home, you can get the help from your spouse. Explain to them. Actually, it should be mutual sharing work, but then our system doesn't give what to say, give way for that still. So explain to your spouse your work is taxing in your institution, and get the help from them also in the household goals, things like that. So you can have more time to rest at home. Explain to your friends why you can't make it to social events. Say, for example, your friends are calling for social events like party, or some maybe relatives are calling for some family occasions. Tell them why you're not able to come. Tell them that you're tired. That's okay. They should be able to understand. Talk it out. Yeah, therapy isn't for everyone, but it's worth a try. Definitely, if there is a chance, you have to go for therapy. If things are really bothering you, better give a try. Bottling up feelings of stress is very unhealthy. Nowadays, there is a lot of online therapies, virtual therapies also is going on, group therapies are going on. You can try them. If your feelings or emotional well-being, you feel that it's altered, you can definitely try them. Bottling up of feelings of stress is very unhealthy, and that can lead to many other consequences in the near future. So do not keep on bottling up things in your mind, or that can which can have an impact. Talk therapy is there. Then cognitive behavioral therapy, all this can help. You don't choose a therapy and go. You just ask for help. You can go to a psychologist or a psychiatrist. They will tell which therapy will work best for you. Unloading some of the stress by talking about it can be refreshing. See, when you talk about certain things, it may be refreshing. Sometimes we have to be honest also about our feelings, at least to but the problem is whom do I talk is a problem. So you need maybe adolescents, they have a best age. They have peers, they have friends, they trust their friends, and they trust each other, they share it. But when you move from adolescence to adulthood, and when you are in 40s or 50s, then it's very difficult to find a trustable person. So identify who is your friend, a trustable person, share with them. Okay, you can try to talk with them. Your feelings are valid, but you may not be able to see that yourself. So have someone. See, you should have someone to substantiate your emotions. And your stress can be a boon for your mental health. Someone who can understand your emotions. Talk to them. Okay, so that that will help a lot. Okay, how to help a colleague suffering from PTSD? We already saw PTSD. Seeking help to deal with ongoing feelings, whether it could be emotional or physical, it is incredibly important. It can take time to process and to heal from any kind of trauma. See, all of us, you may think you are undergoing a trauma. It is not so. A person who may look well, they may also be undergoing a different kind of trauma. Okay, and no one should have to deal with it alone. So you can get the help, or if you are well, if you find your friend or a colleague having an issue, ask them, how are you? You should mean really how they are, and Are you okay? Is everything all right? Things like that. Okay, spare some time. Eye contact is very important. Things like that. So health workers need resilience. Resilience is, say for example, they may be good at, but in between we need resilience. Resilience means what? To set goals, you need some guidance. Okay, so that you can achieve those goals set. To manage the challenges their work can bring. Accessing support systems like counseling, general practitioner visit, friends or support groups can help encourage open communication. See, the person may be in trouble, maybe in stress, or they may require some mental health service, but the person is not able to identify. But as a colleague or friend, you identify that your friend is not doing okay. Talk to your friend and ask them, why don't you go for a counseling or therapy? Even virtually also there are therapies. Okay, ask them, why don't you give a try? Okay, so open communication can help another person. Looking after personal health and well-being can really help during this process of recovery. So what is all important is some stress relief techniques like regular exercise, diet, keeping up the routine. Yes, create a routine. That's very important. Okay, however stressful you were, but if you create a routine for yourself, you are managing, you are coping. Okay, but the routine, you are not able to adapt to the routine also, then you must get the help of mental health professionals. Techniques like meditation and mindfulness all helps a lot. If you want, you can go to a yoga expert and learn how to meditate. Pranayama helps. Be mindful of the environment you are exposed to. What environment you are exposed to, that matters also. When you're already stressed, please don't get exposed to an environment which is provoking stress. Okay, if you want to watch a movie also, choose a movie which is better. Do not continue to work in the same location or undertake same duties and surrounded by similar circumstances to that of the previous traumatic event. Okay, so imagine PTSD is your problem. Don't be in the same circumstance. Try to come out of it. As you speak to your boss, you can manage your routines. The ability to step away when and where appropriate is very important. How long you can bottle up things. Okay, you don't need to bottle up things. Nothing is going to happen if you step away from a situation. Only the moment of taking a decision to step away is important. Maybe that could be difficult, but after that it would be very easy. But think before and you take any decision. Offering understanding and empathy for what they are going through, what your colleagues are going through, or friends are going through is very important. Offering support for that. Okay, all these can help. Tips for talking about mental health to a colleague. Have a conversation. That is the first step. Offering to go to a GP with someone. Yes, one of your friend is not well mentally. Okay, can I, if you want to go to a doctor, I'm ready to come with you. That's a great help you are going to do for them. But again, if your friend is going to trust you, you have to continue receiving the trust, so that by keeping it confidential, things like that. However, don't take control over the situation. Don't decide anything for them. Say, for example, I had a student who was having a psychiatric issue, not here when I was in India, but I took the student to the hospital, to a doctor. She was diagnosed to have schizophrenia, but before that, I got the permission from the parents. Can I take your daughter to a doctor? Is it okay? But the parents cannot accept that their child is having a psychological issue. They said, okay, please take her, but we will come soon. I said, please, you have to come. That was the moment, that was the step for bringing the parents to the institution. because otherwise it could have been as if they don't, they say, the parents when they came said, we sent a very, my daughter was healthy when they came here. But it's not like that. The situations, so many things are there, right? Think about other points of contact if talking face to face isn't working. Sometimes when people are stressful, they don't talk face to face. Or imagine I am not, I am stressful, I don't prefer to talk face to face, but I may prefer to talk through telephone, or I may want to go with my friend for a walk, and then as I walk, I wanted to talk to her. Okay, or sometimes texting the message. Excuse me. Texting also will help. Choose a situation where you are side by side to take the pressure off. While you are driving, you can talk to your friend, things like that. It works. Excuse me. Allow them to open up at their own pace. Yes, give them time. Let them feel comfortable to open up and communicate with you. Do not rush. Do not force a person. That will cause more stress in them. And don't start if you don't have time to help them. Okay, don't force. Don't put yourself into stress and start. It might take several discussions. Remember to look after yourself too. You can't help another person if you are not well. Yes, keep up your health when you want to help another person. Ensure that you are getting enough sleep, eating well, and setting boundaries. Yes, it's very important to set boundaries. Work or family, anywhere, setting boundaries is very important. Yeah. As a healthcare professional, you have to fight stress through preparedness. Plan things well ahead, prepare yourself, and you set a boundary. Okay. So include the possibility of frontline stress control teams. Yes. The boss can, the supervisors or the managers, they can have a frontline stress control teams could be there. Appropriate, there should be a schedule, work and rest schedule should be there for the staff, and support for the needs of providers, family members also. Yes, the healthcare provider, they and their family members also should be getting support. Promoting positive mental health for healthcare workers. Quickly, we will see this. Yes, less than 15 minutes. Within less than 15 minutes, you can do all this. Get outside, turn on some tunes, take a walk, stretch, eat a smart snack, have a laugh. All these doesn't take much time, right? Wish someone well. Maybe you didn't call somebody for a long time. Give a call to them, and then talk to them. Wish them good luck. Connect with someone, as I told you earlier. Do a good deed. Yes, a good deed will make you happy. Sometimes planting a tree or a little plant will make you happy. Sometimes giving food for a stray dog will make you happy. Do a good deed. Clear your mind. Don't keep on adding clutters to your mind. Clear things. Let go. Check the core of your list. Okay, create a to-do list and check what can be done today, or maybe for the summer. What is you have a bucket list for summer and bucket list for winter or spring, things like that. That will help you. Okay, if you had not established what you have planned for the last spring, you can plan for the summer. Give yourself a pep talk here. All these can help. Very important, this is positive affirmations. Yes, many a times when we go stressed, when we feel low, we have to say ourselves, go recollect the past. You were doing great service. You were wonderful, amazing in your workplace. Okay, think of those moments when people appreciated you. Think that you are valuable. I am valuable. I have used these affirmations. I am optimistic. I am powerful. I am abundant. You have a lot of ideas and knowledge, so you are abundant. I am successful. I'm attracting joy to my life. Yes, very important. Are you attracting joy to your life? Yes, if it is so, please. And if you are not, if you are trying to do it also, you tell this, you will be doing it. Okay. I am confidently expressing myself openly and honestly, things like that. Now, another list is gratitude journal prompts. This is very important. So what was the best thing that happened today? Okay, who makes you feel loved and why? Name something that makes you happy, things like that. A big list is there. I'm not going to read all this. Okay, these are all gratitude journal prompts. Okay, so that would help really you, that will help you to make you feel happy. Create a calendar. You can have a routine. Okay, creating a nourishing routine. Yeah, going to a parlor or going to a gym. Maybe if it's for fitness or maybe for well-being, going to a traditional Ayurvedic center, things like that. Whatever is your choice. Anxiety thrives in chaos and uncertainty, all this. Rationalize. Anxiety likes to pull out the worst case scenarios. Okay, reassure yourself. That's very important. Talk. And I'm not going into the talk because we already saw. Schedule. If something triggers your anxiety, try scheduling it on to your week. Okay. Don't put things off indefinitely. Don't delay or procrastinate. Be mindful. Learn to self-soothe yourself. Please do. Always expecting another person to help you may not be good. When you are in the initial stage of trauma or stress, you can soothe yourself. Yes, there are two things. Things which you can control, things which you cannot control. Find out what you can control, what you cannot control. Make a list of. Okay, this is common for everyone. Okay, your attitude you can control, but how others react, you cannot control. Okay, so things like that. You can have active coping calendar. This is a coping calendar what I got during the COVID times. It was very interesting. So you can take a picture of it and you can make yourself a coping calendar. Maybe June, what would be your coping calendar for June? Things like that you can make. What are the actions you're going to take for happiness? Maybe in your workplace, if you have a table, you can have a small candle, a scented candle that gives you happiness. Small things. You don't need to spend a lot. It may not be 1,000 rupees or 500 rupees a candle maybe, but it will stay for much longer time also. Relaxation techniques. Coping with stress and fear, it could be COVID-19 or anything. Yes, relaxation matters. You can meditate, you can do yoga, taking colorful salad, all those will help. Taking deep breaths. They say taking 6 deep breaths can help you to beat stress immediately. Okay. Virtually connect with people, your friends, all. You don't need to go in person and speak to them. Virtually you can connect. Taking breaks from watching, yeah, very important. Take break from watching, reading, going into this Facebook, all those. I have taken a break for almost 2 months now. Okay, it pops up, but I don't care it. So it is, yeah, that's one of the things which you can control also. Make time to unwind. Try to do something else which can make you joyful. It could be silly also sometimes. That's about it. I hope it's clear. When it comes to stress management, we all know most of the things, but we may not be doing. We wanted some help from others. This would be more of help for you, I believe. Thank you all. Thank you for the patient listening. I thank all the organizers, especially Vijaya Educational Academy, and a special note of thanks to Mr. Gopinath, who had been continuously following up during this planning process of the conference, and to all the organizers, co-organizers, the Professor Vimala and the Vice Principal of the college, Mrs. Bharati Reddy. I was there during inauguration yesterday. It was nice. I live in the neighborhood of Vadaparni too. My family is still in Virugambakam. So it was like coming virtually to my hometown now. This session was. Thank you all.
Thank you so much, ma'am. That was a great session on how stress management is actually necessary, and it was really important that somebody comes up and talks about how neglected mental health is and how much we have to focus on that, since we are the ones who take care of the patients as well, the allied health science workers. So thank you so much, ma'am. Thank you for your time.
You're welcome. You're welcome, dear.
Thank you, ma'am.
So I'm leaving.
Sure, ma'am. I would like to share a screen where our partner CBS Publishers actually welcome you for today's second day of Convergence 2022. So kindly look at your screens, people, please. Thank you so much, ma'am. Thank you.
Yeah, I'm leaving here. Thank you.
We'll be moving ahead now with our next presenter. I would like to call Mr. Ramaswat Shah from Tribhuvan University, Institute of Medicine, Nepal. He completed his Masters of Science in Medical Imaging Technology from National Academy of Medical Sciences, Bir Hospital, Kathmandu, Nepal, with 68.63% in 2020. He completed his Bachelor's of Science in Radiological Technology from Tribhuvan University, Institute of Medicine, Maharajganj campus, Kathmandu, Nepal, with a percentage of 75.5 in 2004. He is currently working as a permanent instructor in Department of Radiology, Tribhuvan University, Institute of Medicine, Maharajganj Medical Campus. He has also worked as an assistant instructor in Department of Radiology, Tribhuvan University, Institute of Medicine, Maharajganj Campus. Along with that, he is also working as a resource trainer in Training Institute of Technical Instructions, Sanothimi, Bhagpur since 2014. He has published more than 20 index papers and has conducted various seminars. Sir, we welcome you here with us.
Thank you very much, ma'am. So, good morning, chairperson, co-chairpersons, all the delegates and keynote speakers. So, first of all, I would like to welcome all of you in my presentation, which is on practical practice of filling of CT scan form, theoretical and practical aspects. So this presentation is based on the study performed by me in Department of Radiology and Imaging in Tribhuvan University Teaching Hospital, which is the first academic hospital in Nepal, and literature available on similar study in various countries. So let me share the screen first. Okay, so these are the contents of the presentation. So first of all, the introductions regarding the presentation. So CT scan has an important milestone in medicine, and application of CT has been dramatically increased for diagnosis in symptomatic patients and in screening of asymptomatic patients. So
sorry to interrupt you, sir, but your screen is not visible if you are sharing it.
It's not visible?
No, sir, no. No, sir, your screen sharing is not visible right now. Sir, it's visible now.
Okay, thank you. Okay, so CT scan has been important milestone in medicine, and application of CT, that is computed tomography scanning, has been dramatically increased for diagnosis in symptomatic patient and in screening of asymptomatic patients. So CT is used to answer a variety of queries like evaluating injuries, characterizing and staging of lesions. Presently, many fluoroscopic and conventional radiology procedures have been completely replaced by CT. So day by day, importance of CT examinations is increasing tremendously. So on this basis, I decided to carry out the study. So about 50% of the medical exposure to ionizing radiations is counted for CT scan, and radiation-induced cancer may be an inevitable future with increasing use of CT scans. Thus, it is the responsibility of referring physicians and radiology team to prevent patients from unnecessary exposure to examination. So, International Commission on Radiological Protections has recognized justification as foundation of the radiation protection in practice of medicine, and also suggested that there is a need of effective communication among all concerned and clinical audit to achieve justifications. So it is the responsibility of referring physician to collect adequate clinical information that justify the requested radiological examinations, and it is ethical responsibility of radiological technologists and radiologists to expose the patient to radiations for only justified radiological procedures. So in developing country like Nepal, paper-based radiology request form is the main mean of communication for among all radiological procedures among referring physicians, radiographer, or radiological technologists and radiologists at all hospitals in Nepal. So thus, CT request form must have adequate information regarding demographic detail of the patient, referring unit of the clinicians, clinical diagnosis, provisional diagnosis, proper name of the CT examinations with body part, last menstrual period for female of reproductive age group, renal function test, and previous history of allergy for that procedure involving intravenous contrast agent with type of contrast agent, and status of previous surgery, and signature and name of the referring clinicians. So what is CT requisition form? So for every examinations, we all health professionals know that clinicians write detailed informations about the patient on a form. So similarly, for CT examinations, there is a form on which detail of the patient is written by the clinicians. So a properly filled request form is crucial to understand the clinical problem. And it gives it is also important to give concise radiological reports on diagnosis, and it also helps to avoid unhelpful radiological examinations and radiation exposure. So it also prevents unnecessary delay in making radiological reports. So there is no standard abbreviation. So use of abbreviations may cause confusion and act as barrier for communications, and eventually may lead to clinical error. Thus, it is recommended not to use abbreviation in multidisciplinary workplace. So these are all about the theoretical concepts. So this is the CT request form that that is in use in radiology department of TU Teaching Hospital. So with this concept, I thought to find out what is the status or pattern of the filling of the form in our hospital, that is Tribhuvan University Teaching Hospital. So before starting this study, I gone through several literatures. So in all literatures, what I found is CT request form is a key document for communications among physicians, radiological technologists, and radiologists. And legally, ionizing radiations regulation 2000 states that all exposure to radiations must be justified and optimized. So it is ethical responsibility of radiographer and radiologist to carry exposure only on justified radiological procedures. So thus, a detailed clinical informations must be available on the CT request form, and there are several studies performed all around the world regarding clinical audit of CT request form, and all the study have shown lack of adequate filling of CT request form. So a detailed clinical informations has shown to be beneficial in leading to more accurate reporting and therefore in making more precise diagnosis. Similarly, inadequate information on CT request form cause improper examinations, unnecessary radiation exposure to the patient, misdiagnosis of the disease, and unnecessary delay in reporting. So, questions. So although CT request form is essential communication tool, its importance is highly underestimated practically. So time to time, clinicians are criticized for providing inadequate information on CT request form, which causes unnecessary radiation exposure to the patient, misdiagnosis of the disease, and unnecessary delay in reporting. Thus, question arises, is the CT request form appropriately filled up by the clinicians in the hospitals? So to find out the answer of these questions arise, following objectives were set for the study. So the first objective was set to evaluate the adequate filling of the CT request forms. Second objective was set to find out the frequency of abbreviation used in the CT request forms. And third objective was set as to evaluate the handwriting legibility. So thus this the study this descriptive study was based on analysis of 470 CT scan request forms, and this study was carried out in Department of Radiology and Imaging in Tribhuvan University Teaching Hospital, Nepal, and the duration of the study was for 3 months. And results, actually the study design was descriptive, and the source of data was CT request form received for CT examinations at Department of Radiology, TU Teaching Hospitals. And regarding the results ethics and safety issue, this study was conducted only after approval from Institutional Review Committee of Institute of Medicine, and all safety aspects of the study were followed according to the medical ethics, and all the information was kept confidential. So regarding the data collections, a self-structured checklist was used. So this is the checklist that was used during data collections, and observation of all the CT request forms was used as a technique for data collection. So all the CT examinations request forms received for CT examinations of any type and any part of body for emergency ward and outpatient department of Tribhuvan University Teaching Hospital from 9 a.m. to 4 p.m. 6 working days per week from Sunday to Friday were included in the study, and the examination request forms were systematically observed for name, age, sex, and address of the patient, contact number of the patient, clinical history, provisional diagnosis, history of previous surgery, history of allergy, last menstrual period in case of female of reproductive age, renal function test report in case of contrast enhanced CT scan, name of examinations requested, and date of the request of the examinations after collections. So all the CT request forms were audited. Also audited for use of abbreviations and handwriting legibility. So this is the field checklist during data collections, and data was analyzed using SPSS program version 16 in computer. The findings were presented in the tables, and the categorical variables were percentage as percentage, and frequency were calculated for abbreviations. So here is the result of the study. So among 470 forms, 5 forms were missing the name of the 5 forms were missing the first name of the patients, and among 470 forms, there was no age mentioned on 13 forms. Similarly, sex was not specified on 5.5% of the form. So similarly, there was 412 forms on which address of the patient was not mentioned. Similarly, contact number of patient was not mentioned on 390 forms among 470 forms. So similarly, a CT form without field of date was found 120. Similarly, there was a lack of clinical history on 102 forms. Similarly, there was no history of previous surgery on 447 form among 470, and there was no provisional diagnosis written on 120 forms among 470 forms. So there was not a single CT request form with information regarding history of allergy to any kind of drug. So out of 470 patients, 149 patients were from reproductive age group, and among 149, only 8 forms had LMP mentioned on it. So last menstrual period is very, very important for any radiological examinations from radiation protection point of view. So CT, among all the 470 CT request form, 459 were found with name of CT examination written correctly, while 11 were found with incorrectly written CT examinations as shown in this pie diagram. So on 2.3% of the forms, the name of the examination was written incorrectly. So none of the form was found filled with all the informations required. So regarding accuracy of the CT examination request form filled up in the study, none of the form was found filled with all the information required. So there was no history of allergy to any drug written on any form. Among 470 forms in the study, it was found full name, only first name, age, address, contact number of the patient in 98.93, 1.06%, 97.24%, 12.13%, and 17% respectively. So there are so many similar studies carried out in different countries. So I have compared this study with the study carried in different countries. Similar study carried by different researchers around the world. So among all study, all that study also found the similar findings. That is, there are inadequacy of filling pattern of the CT request form. So a clinical audit of 150 radiology request form at James Cook University Hospitals, United Kingdom, found low interest in providing contact detail on the forms. However, information regarding patient identifier was 100%, and clinical information in terms of brief history and relevant clinical examinations were deficient in all forms. Regarding the use of abbreviations, there was use of abbreviations on 171 forms out of 470 CT examinations request forms in present study. So the most commonly used abbreviation was CA 13 times, followed by SOB 10 times, and LOC 8 times, further followed by SAH 4 times. So these are the abbreviations that was used, that was found during the study, and I provided this list to two senior radiologists working in the radiology department, and they found that the circles, all the circled abbreviations, confusing. They were not clear about these abbreviations. So the use of abbreviations, regarding use of abbreviations, a clinical audit of 444 radiology request form in Pakistan found use of non-standardized abbreviation in 4.6% request form, which is very low in comparison to present study. So regarding handwriting legibility, handwriting was found legible in 424 out of 470 audited CT request form. So a similar finding was seen in a clinical audit of 444 radiology CT request forms, which is nearly equal to the result of this study in this regard. So an audit of 580 radiology request form in one of the tertiary hospital in Nigeria found legible clinical handwriting on 92.63% of the forms, which is slightly more than the result of the current study. So regarding conclusion, this study provides information regarding error in filling pattern of CT examinations request forms at Tribhuvan University Teaching Hospital, and concludes that clinical audit is a key tool in ensuring the radiological examination justification of radiological examinations, which would be facilitated by awareness, appropriateness, and audit. So this study also shows a big gap between theory and practical trend of filling of CT request forms. Thus, this gap must be eradicated to improve quality patient care. So there should be there is no standard abbreviation. So this study also suggests not to use abbreviations in especially in multidisciplinary hospitals. So this study recommends similar studies should be performed in all governmental and private hospitals where radiology facilities are available. So further, the study should be carried by a team of clinicians and radiologists to evaluate proportion of justified CT examinations to provide quality patient care and protect patients from unnecessary medical exposures. So these are the references that was taken during the study. Thank you very much for your patience for listening me, and thank you organizer for giving me the opportunity to share my study findings. Thank you very much.
Thank you so much, sir, for presenting this insightful study with us. I hope we all learned something from this. So moving ahead, I would now like to call Ms. Asha Aklu. She is forensic scientist, Forensic Science Laboratory, Mauritius. She is serving as a forensic scientist from July 2006 till present date. She had a good skill in new learning methodologies and the initial forensic evidences in the place of incident. She is going to deal about the different types of forensic evidences. She has presented 20 plus keynote sessions in international conferences and published more than 15 plus index journals. We welcome you, ma'am, with us. Ms. Asha Aklu, are you here with us? I would like to welcome you all again on behalf of the CBS publishers for the Convergence 2020 in association with SFNP, Society for Nursing Practices, and Vinayaka Missions Research Foundation. Sorry for the delay. Ms. Asha Aklu will be joining with us shortly as she's facing some technical issues.
Good morning, everybody.
Good morning, ma'am. Welcome.
Thank you very much for giving me this opportunity to be present with you all today. So I'm Ms. Asha Aklu from Mauritius, and I work at the Forensic Science Laboratory as Senior Forensic Scientist. So today I'll be taking you to the world of forensic, where we will see how science is being applied and how we apply the theory into practical world. So allow me to share my screen and then we'll go through this presentation. Can you all view my screen?
Yes, ma'am, we can view your screen.
Okay, just give me a second. I'll put it on. Just give me a second. Okay. So as mentioned, it is a privilege for me to be present with you today, just to make sure that we are on the right track. I'm here to talk a bit about the forensic science and how we can apply same in the field of medical aspect and also on any area that we would like to provide evidence for the criminal justice system. Because the aim, can you view my screen just to confirm?
Yes, ma'am, we can view your screen.
Okay. So the aim of the presentation is really to see how with technical innovation, we are able to go further and explore opportunities which were not possible years ago. So we'll see what are the fields that I'll be talking about from physical evidence, what is physical evidence, and how do these enable us to gain evidence so that we can provide the criminal justice system with tangible evidence just to solve crime in different aspects. So what is forensic at the end of the day? It is the science that we use, we learned at the university level or at college level, and then we apply it using different types of methodologies. So starting from the crime scene itself to forensic examination, be it DNA analysis, be it drugs analysis, be it ballistic analysis or toxicological analysis, it is those basics that we've learned at college level that we apply it. So you will recall what is the, we used to have testing regards to analytical, say we are looking for iron. So we take these applications and then we put into forensic science. The main types of evidence that we get from a crime scene, we get testimonial evidence. That is someone committing a crime. So we'll get the testimony of the suspects or of other people involved. But we also get evidence known as physical evidence, which are any material that can link us to the scene of crime, that can link us to the suspect or the victim. We also get documentary evidence, meaning to say that on a crime scene, you will get the documentaries, forged document, video recordings, writings, or anything that can help us to solve the crime. And then we have trace evidence. What are trace evidences? Trace evidence are a type of physical evidence, but they are small, they are present in tiny amounts on a crime scene, and we need special techniques to be able to identify them and analyze them. Some examples are hair fibers, blood, skin cells, or any other items that cannot be seen using the naked eye. So what we'll be talking about in forensic science is mainly the importance of physical evidence. So it is any object that can help us prove a crime. It is mainly one piece of the puzzle that helps us to solve the crime, okay? But we should know that physical evidence is related to the story, that is the history of the case. Some evidences may be important in one case, while it is not that much important in other case. I'll give you a simple example. Say, for example, we have a rape case. In a rape case, we get exhibit the scene was the house of the victim. So in that particular case, the presence of the male suspect would be of evidential value. Now we take the scenario from having the scene of crime at the suspect place. So in that particular case, the presence evidence from the suspect itself won't be of evidential value because he has legitimate access to his room, to his bedroom, or to any place. So you see how a physical evidence based on the type of case history, we can see which physical evidence has enough evidential value and which evidence doesn't have enough evidential value. So when we talk about physical evidence, they link us to the crime firstly. They link us to the body of the victim. They give us information about how the incident occurred. They provide investigative leads so that the investigators can know in which direction to take their case. Physical evidence also enable us to link the suspect to the victim. They help us to link the person to a scene of crime. They help us to eliminate a suspect. So, for example, if I have a scene of crime and I don't find evidence linking my suspect, so it means that I have to find another person instead of that particular person on the crime scene. They also help us to support or disprove witness testimony. This is because, you know, witness testimony is not that much reliable, because I can say something today and then when the case comes to court after years, I'll just retract and say, I won't give evidence, I don't remember. But when we talk about physical evidence, the physical evidence present on the crime scene can help us prove, support what the witness is saying, or can help us say that the witness is lying. So it helps us to support or disprove the witness testimony. And also it helps us in identifying specific suspect. So there are mainly two things that we do in forensic science. A forensic scientist examines physical evidence for one of the two purposes. The two purposes will be identification first and then comparison. Identification is the process of elucidating the physical or chemical identity of a substance, meaning that I'm on a crime scene, I get a bottle, I have liquid in that bottle, I need to identify what it is first. And then I compare it with the library. In a case of drug, I get a chemical substance. It is a white powder. So a white powder can be flour, it can be drugs, or it can be any type of powder. So I need first to identify what it is and then compare it with the chemical component to know which item is it. So it is identification and comparison. The same applies for DNA analysis. I go on a crime scene, I collect DNA evidence, biological material. I will first identify if it is blood, if it is semen sample, if it is bone sample. This is the first part, the identification part. And then using DNA technique, I will do the comparison. So how do we do the comparison? We take the reference sample, okay, suspects and victims of the case, and then we compare it with the evidences gathered from the crime scene. So this will be able to link the suspect to the crime scene, or the victim to the crime scene, or the victim to the suspect. So these are the main two things that we do in forensic science: identification and comparison, but it applies to different fields. So physical evidence versus testimonial evidence. I talked about it a bit earlier. So why do we go nowadays in forensic science to go more for physical evidence rather than testimonial evidence? A person can change his opinion, can give another interpretation, or can give a wrong testimony. But the evidence that we gather from a crime scene evidence, they can't lie, they can't quit, they can't die, we can't forget them, or they get fired, okay? So these evidence are tangible evidence. So meaning to say that what I'm getting on a crime scene on day 1, when I go to court on day 15 or year 15, it will still be the same evidence that will be present, and the value of the evidence will be the same. What changes really with the physical evidence is the interpretation of the evidence that I've gathered. Say from day 1, I get on a crime scene, I get a pistol, I get a knife which is full of blood, and then I get a bottle which has been crushed. Okay, so for me, these are evidences that I gather. Then when the investigation goes on, what happens is that I get more information. And based on the information that I gather, I can then definitely say what was the weapon of the crime. Okay, so you see, the evidence is the same, but the interpretation changes based on information that we gather. Okay, there are also circumstantial variability. That is, if I'm getting evidence in a rape case, it will be of evidential value. But if I get the same type of evidence, say, for example, in a domestic violence case, let's take case A for the case of rape. Okay, for case of rape, you will see that.
Excuse me, ma'am. Sorry to interrupt you. Ma'am, your slides are not changing. Are you sharing a screen with us?
Yes, so let me.
Actually, your slides were not changing.
Okay, let me try again. Thank you for this.
Yes, ma'am. Yes, ma'am.
Can you see the slide now?
Yeah, I can see the slides now. Yes, ma'am.
What is the slide displaying?
Circumstantial variability.
Okay, great. Thank you for that. Okay, so here we are with circumstantial variability. So let me take case A murder case involving the victim is a woman and the suspect, we don't know yet who is the suspect, but we have evidence like the knife present on the crime scene, and then eventually we have disturbance in the room. So after DNA analysis, we can see that we have the profile of the suspect on the knife. Okay, so what does this mean? This means that the evidence that I've gathered is of good quality, a high evidential value. Now, moving from this type of scenario to scenario B, I have a case where a case of domestic violence, meaning to say that the husband and the wife have been fighting, okay? And we suspect that the husband has committed the crime. Okay, and then we get knife also at the crime scene, but the evidential value of the knife, of the DNA present on the knife is not that much of relevance as compared to scenario A. Why? Can anybody say who? Why? Simply because the husband has legitimate access and lives together with the wife. Meaning to say that this type of evidence will not have that much evidential value to the case. In that particular case, the DNA gathered from the knife in the scenario of domestic violence, it doesn't have that much significance for us. And we need to find other sources of evidence to be able to solve this particular crime. Okay, is it changing?
Yes, ma'am. Yes, ma'am,
Okay.
It's changing. Yeah.
Thank you. Perfect. So what do we do is the basics of forensic science, the golden rule, as we say, is when we attend a scene of crime, we never touch, we never change, or we alter anything on the scene until it has been documented. Because once you move something from a crime scene, you touch something from a crime scene, or you move the body or anything, it can't be placed again. When a body or an article has been removed, has been moved, it can never be restored to its original position. So it is very important to document crime scene before collecting evidence. Now you will tell me there are circumstances where we have outdoor scenes. Fine, we have outdoor scenes where it's going to rain and then we have evidence on the road or anything. So in that cases, what do? We document, we collect the evidence, and then we make recording of the temperature, of the weather condition, of anything present at that particular moment to make sure that everything is kept under record before we move any item from the crime scene. I've been talking about physical evidences, trace evidence, and everything. So what are these exactly? When we go on a crime scene, what do we see? So the type of evidence that I'm talking about will be biological fluids. So in a case of rape, you will be having the semen fluid, okay, the seminal fluid. In a case of murder, you will surely see blood present, okay, biological fluids, saliva. We have documents, fibers, firearms, hair, paint, powder residue, soil, vegetative matter, drugs, explosive, fingerprint glosses, petroleum products, serial number, all these are evidences that can be seen on a crime scene. And this list is not exhaustive, so this means that we can have other type of evidence that we get on the crime scene. Do we have any questions so far? Okay, so then we have trace evidence and transfer evidence, that there are some evidence that are present in very small amounts and they are not visible to the naked eye. Whereas transfer evidence, as I mentioned, we have the basic rule of the Lookout's principle. That is, every contact that we make with an object or with something, it leaves a certain trace, but the amount is dependable, okay? Say, for example, I'm holding a pen, I hold my mobile, so obviously there will be transfer of the skin cells, of the body cells to these particular objects, okay? But then it depends on the type of DNA shedder that we are, okay? If you are a person who sheds DNA easily, This means that we will surely find our skin cells on our personal belonging. I'm driving, on the steering wheel, on my mobile, on the pen that I'm using. So these are examples where I can find the epithelial cells, which we call touch DNA. Okay, the epithelial cells. So just to say that there are different types of exhibit that we can gather from a crime scene. We have exhibits that give us class characteristics, and then we have exhibits that give us individual characteristics. And of course, those exhibits who give us individual characteristics, they are of more evidential value. Let me give you a tangible example of what I mean by class characteristic and individual characteristics. We all have a certain type of blood group, yes or no? Okay, it's A, B, O, O, O. Good. So I go on a crime scene and then I find blood. Okay. And then what do? I type that blood to know which group that particular individual is, the donor of this blood is. Okay. So I found that the donor is of group A, meaning to say that all the people present on this room, on this Zoom room, okay, all those who have blood group A can be my potential suspect. Do you get me? Okay, so this is group characteristic. Now, the same thing that I will do is that the blood that I will get, I will do DNA analysis out of it. Getting the DNA from the blood sample will give me the profile, a DNA profile of one individual, or it can be a mixture. Okay, say we have the DNA profile of one individual. What will I do? I will do the DNA profiling of all of you people present in this Zoom room. And then I will compare that with the sample of blood that I've got on my crime scene. From this, I can pick one person in the Zoom room whose DNA was present on the crime scene. Okay, so individual characteristic, it goes directly to the individual or to a specific class, to a specific group that gives us unique identity, okay? Whereas class characteristic, I will get blood, I will get the blood group A, B, O, etc. Hair, the fibers, the color. But when we talk of individual characteristic, it's giving the identity of the person, okay? So with forensic science, what do we do? What do we get? From a crime scene, we can get blood samples, and then eventually we can get blood stains that can be viewed with enhanced. So for example, we often get that, especially in Mauritius, crime scene that have been washed, that have been restored so that we don't know that there was a crime scene over there. And then we use techniques such as chemiluminescence to make sure that we can see a stain. Yeah, as you can see on the photograph over here, in the first part, there was a cupboard. We don't see the blood stain, but then with enhanced technique, you can see the blood stain in the cupboard. Okay, here also for the bathtub, initially there was no blood stain visible, but with the enhanced technique, we can see the blood stain. Semen stain, so these we get on the exhibit, and then we do microscopical analysis. After the microscopical analysis, using the staining techniques, we can see the sperm cells, and if after seeing the sperm cells, we confirm their presence, we go for DNA analysis. Hair examination, so types of hair that we get, it can be human hair, body hair, animal hair. We can say if the hair has been dyed. If the hair has root, we can go for DNA examination. Examination of fibers, forensic entomology. So if we get a decomposed body, the type of insect present around the body can give us an indication of the time of death, how many days the body was present over there, etc., etc. So these give us information about the case itself, okay? Facial reconstruction, so if we recover human remains or bone, we can do facial reconstruction to know what, if it is a male or if it is a female, or we can also go for DNA analysis to give the identity of the victim. And then we have drug analysis, so the type of chemical, going deep down into defining if it is cannabis, heroin, cocaine, or etc. And now since recent years, we are getting a lot of cases of synthetic drugs in Mauritius, which has caused us to review the law, because there are chemicals that are being present in the synthetic drugs that were not qualified under the Dangerous Drugs Act. So even if we get the synthetic drugs, we could not say it is an offense because they were not listed in the Drug Act. So we had to construct a new library to make sure which are the synthetic cannabinoids that can assist in making synthetic drugs, so we can classify these chemicals also and charge the person for drug dealing or trafficking. Okay, so the type of drugs that we get: cannabis, heroin, amphetamine, cocaine, LSD, synthetic drugs, psychotropic drugs, and then these are types of drugs that are smuggled at the airport or any that they come into the island, so we are able. And then we do also fingerprint identification, okay, footwear impression. So this gives us an indication of the type of footwear, and we can also relate to to the suspect, because you will see each and everyone has their own way of wearing and tearing of their shoes. So this can help us, even if it is a close characteristic, it has been help us identify suspect on the crime scene. Once again, we identify and then we compare with the exhibit provided by the suspect. Footwear impression, so we can get that, not necessarily a nice one like you see in this picture, but we can get partial footwears so that it enables us at least to have some indication on the type of shoes that we are getting. So you will see this is part of the footwear, but it enables us to relate to the exhibit. Enhanced chemical, I said. So this is a corridor of a murder case. So you will see that we don't see the blood traces right here, but with enhanced chemical analysis, you will see that there are footsteps that we can identify on the corridor with enhanced chemical analysis. And then there is document analysis, forged signatures, fake currency, false lottery tickets. So these examination, we do it. So forge expiry dates. So all these digital and computer forensic becoming more and more important in nowadays with the improving technology and everything. So these are gaining much more importance, and it is simply by applying the basic science that we know in the relative field. Okay, we also do forensic ballistics, meaning to say that whatever we get from the crime scene, we can compare it and make it and relate it to the type of gun being used. But more important, we can also use today with the technology available and the type of analysis that we use gunshot residue, meaning to say that when someone is firing, there are residues of gunshot that still remain on the clothing or on the surrounding of the crime scene. So by analysis of the gunshot residue, we can define where the crime scene was initially, that is from where the person was firing, or we can also link the person to the crime scene by analysis of the clothes that it has been working. So there is a famous case in Mauritius where there were Somalian pirates that were they were suspected to be pirates, Somalian pirates. So we took their clothes and then we analyzed them for gunshot residue, and it was a positive case. We do fire investigations. Okay, the pattern, road accident, forensic technology, using the techniques to analyze if there are drug metabolites in post-mortem samples. And then we have also forensic botany. We can also compare the tool marks present on a case of larceny where there has been forged entry with the type of tools being used. Okay, so using a comparison microscope, we can see the striation mark, if it is the same or not. Tire mark also in the case of accident, where we can find tire mark on the clothes of the victims. Serial number restoration, there are many for vehicles, boats, etc. So we can see if it is the the original serial number, or if there is a type of forgery in that. We do also physical fit. That is, we get pieces of substances from a crime scene, and then we can get another one from the car, and then we can do the physical fit to say that part A is part of part B. Okay, part A and part B, or we can define what type of exhibit it was. So for paint analysis, it can be transferred. So for example, if a car was involved in an accident, we can still do the scratching and see if it is the car or if the car has been repainted. We also get paint transfer, that is paint flakes on exhibits of victim that help us to say that at a certain point in time, the clothing of the victim was in contact with that particular vehicle. So comparison and identification for glosses also. Now, returning to the title of this presentation, how does innovation, that is the application of the knowledge and methodologies of various science disciplines, providing evidence for criminal justice system in the field of DNA analysis? Let me go a bit into detail on this part of my presentation on DNA analysis. So what is DNA? Okay, we all know that it is the genetic material. When I'm talking in this presentation, I'm talking about human DNA, so human identification. Okay, so it is the biological material that is transferred from the parent to the offspring. So the mother gives half set of the DNA to the child, and the father gives half set of DNA to the child. Yes, but when we talk about forensic DNA, we're not talking about the characteristic about the traits, the hair color, the eyes color, length, etc. No. When we talk of forensic DNA, we are talking of the non-coding region of DNA. Okay, there comes the application of molecular biology. So what is a coding region? What is a non-coding region? Okay, and we talk about the analysis of short tandem repeats, meaning to say that I have a characteristic. Okay, so what do we do for forensic DNA analysis? We analyze, actually in Mauritius, we are analyzing 16 locus. Okay, so one locus is part of the DNA. So as part of this DNA, half is given from the mother and half is given from the father. Okay, say for example, at locus A, okay, of my DNA, I have 15 tandem repeats from my mother and 20 for my father. So at locus A, my profile is 15 and 20. For you, if you have been receiving 20 from your father and 16 from your mother, it will be 16 and 20. Okay, so like this, we analyze 16 locus. And this is unique for any individual except for identical twins. So this is what we exploit in DNA analysis. So when we talk about a DNA profile, it is the analysis of the loci on the DNA, the non-coding loci, and we call that the short tandem repeats. Okay, so how come that evolution in innovative technology, we started from simple analysis where we could not use individual characteristics. Say, for example, from a crime scene, I got blood. From that blood, I could only say if it is A, B, ABO, or anything like that. Okay, but with DNA, forensic DNA analysis, I can challenge and say which person has contributed, who is the genetic donor of that profile. I can go directly to an individual, okay? But it is a very sensitive method, meaning to say that we should know how to recover samples for DNA analysis. We should know how to treat samples of DNA analysis because it is very sensitive, okay? If you go on a crime scene without wearing proper protective equipment, you are providing your DNA to the crime scene. Okay, if you handle exhibit without wearing gloves, without wearing proper protective equipment, so you are providing your DNA sample to the exhibit. Okay, so we should take into consideration the issue of contamination. Okay, and at the end of my presentation, I will tell you how do we tackle this in the in labs in Mauritius. So the evolution of forensic DNA, you will see that we started in the 1900 with the blood typing group. So I was talking about class characteristic A, B, ABO, and O. Okay, and then we move forward to 1916, where we talked about protein isoforms. And there comes the DNA fingerprinting by Alex Jeffrey. And then we move towards, in 1990s, the STR-based DNA typing, that is the non-coding region of the DNA. And then we started, now we know that DNA is a powerful tool, as from 1990, as from 1980s. So what is the aim now is to optimize and get maximum information that we recover from the crime scene, meaning to say that we are going deeper into the DNA molecule now, okay? Where initially we just started gel electrophoresis, typing the type of gene or the type of specific locus. It took time, it was lengthy, but now with commercial kits, we call multiplexing. That is, at the same time, we can amplify from 9 to 32 loci of the DNA, and then we do the analysis. Okay, and then in 1997, there are the CODIS 13 loci, which are international loci. Say, for example, I'm doing a DNA analysis in Mauritius, and you're doing forensic DNA analysis in India or in America. So there are 13 loci, which are called the 13 CODIS loci, that are common in what I'm doing here, what you're doing in India, and also what is being done in America. So if ever I have to compare a DNA profile that I've received here with any of your DNA profile and that of American profiling, so there is some standardization, and I can do the comparison. Okay, and then we've seen that in the year of 2000, so we started from capillary electrophoresis to the expansion of going deeper into the DNA using NGS, that is next generation sequencing techniques. Okay, so if you're talking about the DNA workflow, how do I get a profile from a knife, or from a blood stained clothing, or from a reference Becker subsample, or from samples of the autopsy, the blood that has been retrieved by the forensic pathologist? So what is DNA processing? So we've seen the collection of evidence that is done on the crime scene or at the mortuary. And then what do? We try to identify what it is. If it is blood, if it is saliva, if it is semen sample. What do we have to do now? You know the basic structure of a cell, yes or no? You know, you've done all, at least the basic biology, what is a cell, what is the nucleus, okay? So in forensic DNA typing, we're actually talking about the nuclear DNA. So you know what is the cell, the cellular membrane, and then there are mitochondria, the cytoplasm, and then in the middle of the cell lies the nucleus with the nuclear envelope. It is that particular DNA fragment in the nuclear envelope that I'm targeting for forensic analysis. So what do I have to do? I have to break the cell, remove all the content so that I have the DNA strands. Okay, this can be as in high quantity as in a pool of blood, or it can be as in a minimum quantity as touch DNA on a glass. A fingerprint also, we can use it to have DNA, okay? So we do a process where we have to separate the cell content and the DNA. So this process is known as DNA extraction. This uses the principle of breaking the envelope, the membranes of the cell, using different types of buffers, different types of chemicals to break down the cell so that it liberates the DNA, okay? And then for DNA analysis, we need to know if we have enough material to go ahead to have a DNA profile. So what do? We quantify the DNA that we receive from the extraction. Once we know how much DNA, why is this step of quantification important? Because eventually I need to know what technique or what will I do with the amount of DNA I get. Okay, it will go for amplification, meaning to say that I will make millions of copies of the DNA fragment that I have. Point to be noted that too much DNA is not good for DNA analysis, and too little DNA also is not good for DNA analysis. So we need to have a right amount of DNA, okay? So using real-time PCR, we do the quantification, okay? And then based on the information that we get from real-time PCR, we know if we have to dilute our sample to get a proper profile, or we know if we have to put maximum of the sample for amplification to get a profile. Okay, We've done the extraction, we've done the quantification, we've done the multiplication, the copies of the DNA. Now we need to analyze it. Analyzing the DNA uses, means to say that we're going to read what is in the extraction that we've got, and then we get the results. Okay, so with technology, okay, we've seen that there has been innovation at any step of this particular DNA workflow, using simplified techniques, ensuring that there is a first pass success rate, meaning to say that I get my sample at the end of the workflow, I get a DNA profile, I don't have to modify steps in between. Okay, so we've seen that there has been an evolution using technology and modern techniques from organic extraction, which is the phenol chloroform extraction. We had Chelex extraction, which is using silica beads. And now we have commercial kits that uses beads to be able to bind the DNA, and then upon certain circumstances, we wash the sample, different types, and then afterwards we elute the DNA that is being used for quantification. And then we use the quantification that is real-time PCR. The upgrading with real-time PCR, we've seen that with time, you're able to see the degradation rate of the sample, and if there is any inhibition, the presence of inhibitors that will affect our result eventually at the end of the workflow. So this information we get from quantification. We can, from quantification itself, know if the sample contains a male or a female. Okay. Okay, so yeah. And then from real-time PCR, we started using commercial kits that does multiplexing. That is, instead of doing PCR for one locus and then start the process again for another locus, start the process again for another locus again, with commercial kits now in a same append tube using the different markers and mixtures, you can amplify from 9 to 32 loci. Okay, so it increases the amount of DNA, the amount of information that we can get from a sample that has been extracted. Okay, we are talking about short tandem repeats, but we also have kits that have been designed to analyze the Y fragment of the DNA. That is talking about the male aspects. Okay, it's not about the Y lineage. Okay, so it's the further line, okay, that we will be getting. And also minifiler kits. So there are cases where we get very degraded sample. So instead of we reduce the length of the STR being analyzed, so we use the minifiler kits. Now, looking forward to the analysis part. So the analysis means that initially, when we started DNA analysis, it was using gel electrophoresis. You know, the block of gels, you put the dye, everything, and then loading the gel, applying the current, seeing the bands, okay, to know which DNA we have, which DNA we don't have, and then we compare. With increasing technology, using new methodologies, we've now shifted from gel electrophoresis to capillary electrophoresis. Okay, capillary electrophoresis giving us option if you want to have 8 capillaries, meaning to say that 8 samples at a go will migrate in their own capillaries, or we can have up to 16 capillaries. Okay, that means to say that at a point in time, there are 16 runs being carried out. And with the latest methods, so it is about next generation sequencing, where it is no longer about the STRs, but it is mainly about the single nucleotide information. So we move from gel electrophoresis, okay? So this was a way that we used to identify cases using DNA. So you have the ladder, you have from evidence 1, evidence 2, evidence 3, evidence 4, and then we also have from reference sample A, B, C, and D. So what you have to see, evidence 1, it matches which band of suspect A, B, C, and D, and like this, you compare who was the suspect at evidence 1, evidence 2, evidence 3, evidence 4. Okay, so with this, we could not go really into getting more information than this, okay? And it took time depending on the number of samples that we can load on the gel, Okay, and very often, you know, the technicalities just are not well set, everything, so we have to run over again. Okay, and then it came that we have the capillary electrophoresis. I've just put two types of capillary equipment in front of you to tell you how innovation has proved to be something very efficient in reducing the amounts of time that we have hands-on on the equipment, and in using today cassettes and capsules that can readily plug into the material into the equipment that can be used with minimum handling, as I mentioned previously. So DNA is very sensitive. The minimum the amount we have hands-on time on the sample, it is better for us to get efficient results. Okay, so on the left side, you will be having a genetic analyzer, the first series, 31-3000 series. Okay, so you will see that the analysis is based on separation of the DNA molecules that have been amplified, okay, based on an electric current, and there is it moves through the capillary, okay, over here, moves through the capillary, and then there is a detection window, okay, that measures, there's a CCD camera that measures the intensity of the dyes, and then a software that analyzes which DNA it is, okay. Now with the latest technology, the capillary is in this blue part, so you need not touch the capillary, it is directly onto the apparatus, and then you have, instead of diluting the buffer, preferring the buffer, everything. So you have everything that is in small cassettes, you just have to plug it into the apparatus to make sure that it reduces the amount of time for the to get a profile with the sample. So if initially it took like 5 hours to get a DNA profile, now within 3 or 2 hours, you can already get a profile, get it run doing. Okay, so this is a slide showing the principle of migration, that is from the anode to the cathode. The molecule we move based on the size of the molecule, the charge on the molecule, and then moving through the detector, it is analyzed and we get a profile. Okay, so what do we analyze? As I mentioned, short tandem repeats. So this is a tandem, 1, 2, 3, 4. You will see that the 4 are the same. Okay, and then below you will see 1, 2, 3, 4, 5, 6 block of same. So it would say that at this particular loci, my profile is 4 and 6. Okay, and this is a profile which we get from a mixture profile. How do we know it is a mixture profile? If it is a single source profile, there would have been 2 peaks at a particular locus. But here we have more than 2 peaks, means that it is a mixture profile where we have more than 2 contributors. Okay, so now where have we reached with innovation and technology? We've seen that for tandem repeat, it is counting the blocks, but at times there are errors within the blocks. So with next generation sequencing, we are now able to see what is the difference at single nucleotide level. So this is called single nucleotide polymorphism. Still under validation in many laboratories, not yet being fully implemented, but it is an important technology for mitochondrial DNA analysis. What we were talking during this presentation till now was about the nuclear DNA. But we also have mitochondria as organelle within every cell. And the organelle, the mitochondria, they have maternal DNA. Mitochondrial DNA means that you inherit your mitochondria from your mother. Okay, so with technology, we are now able to identify and go deep into the mitochondria to see what heritage have you been receiving from your mother. And it helps in crime scene because there are certain cases of human remains where we don't have nuclear DNA that much, but we are still able to recover DNA from bone sample. And these help a lot in providing information about the maternal lineage of the bone sample or human remains, okay? So when we talk of DNA analysis, we are talking about samples, the reference sample, exhibit that are being brought to the lab from the crime scene. So the challenge really is to recover DNA profiles from minimum samples recovered and to make sure that we are able to use it for the laboratory. I go back to the question to say that DNA is very sensitive. Okay, it is like a bottle of milk. If you put it on the table under conditions, it can go rot, it can turn over. Okay, so how do we ensure the integrity of the sample using technology? There is something which is magical, which every lab is turning to now. It is the quality management system, the ISO standardization, meaning that it is standard norms that regulate the activity of testing and calibration laboratories to ensure technical competence, okay, on the reliability of results. To cut short, it is to say that what I'm doing in Mauritius, I'm doing it under using standard methodologies. If you're doing the same thing in India, the same thing in America, so we can compare our results. It also shows that I am doing everything based on international laws. Okay, say for example, handling of exhibit, DNA. So for laboratories, we have the ISO 1705.2017, which is specific for lab area. Okay, having a certified lab ensures professionalism. That is, I know that the result that I'm producing and giving to court is something reliable. It ensures the chain of custody and the integrity of the sample, meaning to say that from samples being brought to the lab, we have not mingled with that. We have not contaminated the sample. We are respecting all the norms for the processing. Okay, and it gives international recognition, as I mentioned. So what I'm doing here, I can compare my results with any lab performing the same techniques and the same under the same conditions. Okay, it gives reliability of results, meaning to say that I know that what is being given to me, I follow the rules and regulation, and there are audit trails of what I've been doing, who has been working with the exhibit, who has been involved in XYZ process, and where I am today. The result is something of credibility. Credibility of results, identification, and evidential value of items. So all these are at the end of the day submitted so that we can give evidence and help to solve criminal investigation. Okay, so this will bring me to the end of my presentation, saying to say that the application of modern technique in forensic science is playing a pivotal role in conducting in-depth analysis and elucidating crime that were not able to be solved decades ago. So if we compare DNA analysis and the way that crimes were solved years ago, we are more into credibility, more into professionalism, more into physical evidence, to say that the evidence that we can produce at the lab has been using applied sciences, has been using validated methods, and has been, especially here, using modern techniques to be adapting to the new era, that is the technological era in which we are living. So with that said, I would just like to thank you again. And I hope that with this presentation, you've been able to discover a bit of the forensic world. Time is limited, I know, and it is something that you can go ahead talking and talking again. But I thank you for this privilege to be here with you. And I hope that during my presentation, you've been able to grasp at least a few things that you will be able to see how sciences are important in our daily life, being in the nursing sector, being in the pathological sector, or being worldwide. At least we are moving inwards, meaning to say that what we see at the surface was a phase, was a period, but now in this era, we are going deep within, meaning to say that we are really working at the molecular level and nano level, and applying these techniques help us in different fields just to be able to serve a better purpose of what we are supposed to do. Thank you very much for your attention. I'll be pleased to take any questions.
Thank you so much, ma'am, for this insightful presentation. I think we all did really learn something related to forensic science, and it was a very, very interesting topic. So
thank you.
I would request the audience, if you have any question, you can definitely ask ma'am in the chat box. She will be happy to answer you.
Yes.
Okay, so we will be moving ahead now. So moving ahead, I would like to I would like to welcome you all from nanotech company, and I would like to display their products as well. I would like to play this video as well. Kindly go through their products. I welcome you all again from Nanotech Company for this conference.
A lot of Hindu girls and women have been taught that they aren't allowed to pray when they have their period, which, by the way, is completely wrong. It's a myth, and it just got passed down through generations, but that's not the reason why we don't pray when we're on our periods. And let me explain why. First, let's talk about the Ayurvedic perspective of it. During a girl or a woman's period, Ayurveda indicates that our bodies are going through a cleanse. And basically, the body builds prana. Prana means energy, life, and force. And that entire time of building that prana energy, you finally build up to it and you release it. Ayurveda also mentions that women on their periods are more likely to spread their energy and absorb the energy around them. So the reason why women were told not to go to the mandirs or do puja while we're on our period is so that we don't catch any bad energy while we're on our period. It's to protect us from fatigue.
I hope the video was helpful. The company's name is Neotech. So I welcome you all again for this conference, and I hope you all like their products as well. So now moving ahead with today's conference, I would like to welcome our next keynote speaker, Dr. Rezwan Montazeri, Chief of Chemo Ward, Amiria Clinic, Tehran, Iran. Basically talking about her experience, she is currently working as Chief of Chemotherapy Ward and Amiria Clinic from October 2021 till present date, Shahryar country, Tehran in Iran. In May 2020, she became the International Advisory Board member of Asian Pacific Journal of Environment and Cancer and is serving the same till present date. She is also the advisory committee member of International Association of Oncology. From 2018 till current date, she is also the radiation oncologist in Qazvin University of Medical Sciences, Vilayat Hospital. She has completed her radiation oncology residency program from 2014 to 2018 from Shahid Beheshti University of Medical Sciences Residency of Radiation Oncology. She also completed her medical residency program general certificates from 2004 till 2011 from Lorestan University of Medical Sciences. I welcome you, ma'am.
Hello.
Hello, ma'am. Welcome, ma'am.
Thank you. May I share my
Sure,
screen? Yes.
Yes, ma'am. You can share your screen.
Excuse me. Can you see my screen?
Yes, ma'am. It's yeah, it's visible.
Thank you. Hello, everyone. I'm Dr. Rezwan Montazeri, radiation oncologist from Iran. And it's my pleasure to be here today. And I appreciate to my Indian colleagues for inviting me to Convergence 2022. And I want to present a topic about the radiotherapy role in palliative care and awareness and responsibilities of healthcare persons. And I use the International Atomic Energy Agency guidelines for palliative radiotherapy. This report especially recognized the role and potential of radiotherapy as a cost-effective palliative tool in cancer care, while also emphasizing the need for training in comprehensive palliative care among the radiation oncology community. This report summarizes current approaches to palliative radiotherapy and outline the steps needed to enhance access to palliative radiotherapy and improve the quality of palliative care as a whole through a more integrated and multidisciplinary approach. And at the first, let's look at some data about global burden of cancer worldwide. According to WHO, the global burden of cancer is burgeoning, and it's estimated that more than 1.9 million new cases of cancer will be diagnosed in 2022. And as you can see in the chart, prostate cancer is the most common cancer among males with 27%, followed by lung cancer and then colorectal cancer. Among females, breast cancer is 31%, and then lung cancer and colorectal cancer. And we know Asia comprises roughly 1/3 of the world's land area and about 3/5 of its population. According to United Nations Economic and Social Commission for Asia and the Pacific, UNESCAP, the continent includes the two most populous nations in the world, China and India, which together account for some 2/5 of the world's population. And literally, it's estimated that in the future, more than half of all cancer cases will be diagnosed in low-income countries, and about 80% of these patients will have incurable disease at the time of diagnosis. Based on these statistics, palliative care will remain one of the most important worldwide interventions in oncology. And we must know each year an estimated 40 million people are in need of palliative care, and 78% of them people live in low and middle income countries. Worldwide, only about 14% of people who need palliative care currently. And WHO definition of palliative care is an approach that improves the quality of life of patients and their families, and their families who are facing problems associated with life-threatening illness. And according to this definition, that such care should provide relief from pain and other distressing symptoms, and affirm life and regard dying as a part of the life cycle, intend neither to hasten nor postpone death, and offer a support system to help patients live as actively as possible until death. Offer a support system to help the family cope during the patient illness and in bereavement after the patient dies. This support should also address the specific needs of children, and use a team approach to address the needs of patients and their families, and including bereavement and counseling if indicated, and enhance patients' quality of life and positively influence the course of the patient illness. And there is here the American College of Surgeons statement of principle of palliative care. You know, These principles are very useful to know when we face with in the stage people with cancer. One, respect the dignity and autonomy of patients and patient surrogates and caregivers, and two, honor the right of competent patient or surrogate to choose among treatment, including those that may or may not prolong life, and communicate effectively and empathetically with patients, their families, and caregivers. Identify the primary goals of care from the patient's perspective and address how the medical care can achieve the patient's objectives, and strive to alleviate pain and other burdensome physical and non-physical symptoms. And 7, six, recognize, excuse me. Recognize, assess, discuss, and offer access to service for psychological, social, and spiritual issues. Provide access to therapeutic support that encompasses the whole spectrum of care, from life-prolonging treatment through to admission to hospice, when the physician can realistically be expected to improve the quality of life as perceived by the patient. And recognize the physician's responsibility to discourage treatments that are unlikely to achieve the patient's goals, and encourage patients and families to consider hospice care when the prognosis for survival is likely to be less than 6 months. And arrange for a continuity of care by the patient's primary or specialist physician, thus alleviating the sense of abandonment. Patients may feel where curative therapies are no longer useful, and maintain a supportive attitude toward others entrusted with the care of the patient. We must know palliation represent a large component of cancer treatment, and includes the use of therapeutic measures such as radiotherapy, chemotherapy, surgery, and supportive care measures like opioids and other analgesics. And if we want to know about our real current status, we should know that healthcare systems in most Asian countries are typically financed by out-of-pocket payments by individuals. The majority of Asians do not have health insurance. Hence, the cost of treatment for any of one family member is borne by the entire family. Where there is no financial risk pooling mechanism, poor people have to meet the costs of healthcare from out-of-pocket payments, driving many households into poverty. And many epidemiologists and health policy workers have been warning about Asia's approaching cancer epidemic resulting from an aging population, high rates of tobacco use, and increasing rates of obesity. And the number of new cancer cases in Asia is set to increase from 6.1 million in 2008 to 8.3 million by 2022. However, most of the patients in Asia are too poor to afford expensive treatment, and we must consider it. Actually, there are several challenges present when dealing with the cancer burden in Asian countries. For example, 1/4 of diseases among middle in India are caused by smoking, and it is predicted that as many as 100 million Chinese current male smokers will die from tobacco use. and the prevalence of H. pylori infection, which significantly increases the risk of gastric cancer in Asian countries with low socioeconomic status, is extremely high, reaching 92% in Bangladesh and 79% in India and 58% in China. The endemic of hepatitis B in South Asia also considerably increased the risk of hepatic cancer. And many barriers prevent access to radiotherapy services in Asia. Services are usually provided only in metropolitan centers, and many patients need assistance for travel and accommodation during their treatment. Though some of the Asian countries, including India, have established national cancer control programs based on WHO guidelines, and the status of radiation therapy in low and middle-income Asian countries, especially in the poorest of countries, is not well developed. And it should be noted, however, the cultural barriers to resource development can be equally as important as the financial, educational, or logistical barriers outlined. And a case in point are many countries in Middle East where there has been little advance in palliative care, despite expensive resources and booming urban development over the past 50 years. And actually, approximately 50% of new cancer patients in high-income nations are treated with radiation therapy. Using that statistic, there should be more than 2 radiation oncologists per 1,000 cancer incidents, but only just 4 Asian countries currently meet this criteria, as in other low and middle income nations, most Asian cancer patients present with advanced cancer. Although these patients require shorter courses of radiotherapy, and the number of cancer patients needing radiation therapy is still remains much larger than can be managed with the limited capacity and resources. And additionally, many radiotherapy units in low and middle income Asian countries do not have proper quality assurance and maintenance systems. And even a statistically adequate number of radiotherapy units, however, do not necessarily ensure delivery of treatment to the whole population, since accessibility may not be guaranteed. This factor is especially significant in countries where the population is scattered over large areas or many islands, and the cost of treatment also affects the accessibility to radiotherapy, as low-income patients cannot afford the cost of curative or even palliative radiotherapy. And studies from high-income countries have shown that palliative radiotherapy costs only about 1/8 of the cost of curative therapies, and was more cost-effective than analgesia alone or palliative chemotherapy. These costs might not be directly comparable, but the qualitative result is likely to be the same in low and middle income Asian countries. And another thing, it is about training programs for radiation oncologists and technologists, and differ between and even within Asian countries. Many Asian countries have a variety of training programs in palliative care for doctors and nurses, but none of them are specific to radiation oncologists or palliative radiotherapy. And palliative medicine is an accredited medical specialty with a specific postgraduate training program in several Asian countries. And we must know palliative care is also included in the undergraduate medical and nursing curriculum in many medical and nursing institutions in these countries. A palliative care strategy must include training in palliative care and palliative radiotherapy for all healthcare professionals, along with planning for development of radiotherapy services and investment in equipment. And we must know this is especially important when cancer cannot be eradicated. Treatment for palliation is intended to control the symptoms of disease. Controlling symptoms of disease relieves suffering from pain and prevents loss of functional integrity, for example, paralysis from spinal cord compression. And unlike other aspects of cancer therapy, tumor control and survival are not the absolute endpoints of therapeutic success in palliative care. And research shows that approximately 30% of patients with newly diagnosed cancer and 30 to 50% of patients undergoing treatment and 70 to 90% of patients with advanced disease experience pain. Recognizing that cancer patients may experience pain at diagnosis, during treatment, and after treatment when cancer recurs means the pain is considered one of the most negative factors affecting the quality of life people with cancer. Pain interferes with normal daily activities and prevents relaxation and sleep and increases stress and fatigue. And while many tumors do not cause pain at diagnosis, tumors that cause obstruction of the respiratory, gastrointestinal or urinary tracts often have pain as their first symptom. And there is a difference between palliative care and supportive care that we should know it. Actually, palliative care is defined as an approach that improves the quality of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Although many associate palliative care solely with end-of-life care, it is increasingly used to refer to symptom control throughout the course of cancer. And but supportive care is defined as treating the adverse effects of cancer treatment, including nausea and vomiting, infections and cytopenia, mucositis, malignant effusion, oncologic emergencies, and bronchoplastic syndromes, and nutritional support. And it aims to optimize the comfort, function, and social support of the patient and their families at all stages of illness. And excuse me, my screen isn't changing.
Yes, ma'am. Your screen is not changing, ma'am.
Please let me share again.
Sure, ma'am. Sure, ma'am. You can share the screen again.
Yes, yes. Excuse me for disruption.
No problem, ma'am.
You know, just 18 slides of my PowerPoint has loaded, you know.
No problem, ma'am. If you can just say or read your slides, and I think that will also be understandable by the audience.
Okay, I can go on, but you know, you can't see my screen because just 18 slides has been loaded in this. I don't know why. Okay, it works. Please wait. Excuse me, audience. Okay. Radiotherapy is one of the most effective means of providing palliation of cancer symptoms. The symptoms most commonly relieved with palliative radiotherapy are pain, bleeding, and obstruction caused by the tumor. And we must know the role of radiotherapy in palliative cancer treatment should be recognized, especially where other forms of palliative treatment may be unavailable, because the availability of radiotherapy services is closely linked to the level of medical care and the economic status of a given country. And we should know the symptomatic side is more important to the radiation treatment plan than whether the symptom is caused by local advanced or a metastatic tumor. And common sites palliated by radiation, either alone or in combination with other treatments, include tumor involvement of the lung, pelvis, skin, and subcutaneous tissues, brain, and bone. And the three most common types of cancer, lung, breast, and colorectal cancer, have high rates of metastatic spread to bone and visceral structures. And actually, bone metastases are the most common cause of cancer-related pain, and over 70% of patients with bone metastases are symptomatic. Palliative radiation is especially important in weight-bearing bones responsible for ambulation and activities of daily living. And one of the most important goals in the treatment of bone metastasis is to relieve suffering and maintain independent function. And several meta-analyses show that the overall response rate is 60% and the complete response rate is 33%. And for a patient with metastatic disease, time is very critical. The time under radiation needs to be considered as the opportunity cost of palliative treatment. If the median survival of a patient with bone metastasis is 6 months, the patient will spend 0.6% of the remaining survival time under radiation treatment when a single fraction of radiation is given. Actually, even if retreatment with a second single fraction is required, the patient will only spend about 1% of the survival time under radiation therapy. If 10 radiation fractions are given, 8% of the remaining survival time, and if 20 fractions are prescribed, 16% of the remaining survival time will be consumed by radiation therapy. And we must note about radiation toxicities. ICAHS radiation toxicities are linked to the dose per action, total dose, and the area and volume of tissues. And to maximize quality of life during the course of cancer, the use of radiotherapy for symptom prevention and symptom management is needed. Patient quality of life should remain a priority for both curative and palliative cancer treatments, and in the healthcare professionals must incorporate quality assurance measures at all levels of care. And among family physicians, 97% had recently seen cancer patients in their offices, with 85% regularly caring for patients with advanced cancer. You know, cancer patients are diagnosed and treated by nearly every medical specialty. And a survey has shown that physicians who are more knowledgeable about the common indications for palliative radiotherapy are significantly more likely to refer patients for radiotherapy. The accessibility to radiation oncology services was also an important factor for family physicians to refer patients to palliative radiotherapy. And it is important to recognize that even in high-income nations, not all cancer patients are referred to a cancer specialist, and just only 10% of physicians had received radiotherapy education during their formal medical training. And quality assurance is a priority in radiotherapy since the treatment outcome of patients improves with appropriate and safe and effective radiation. You know, actually the whole process of radiotherapy has multiple interrelated and integrated procedures from treatment prescription to delivery. It is of particular importance to provide a systematic, comprehensive, and highly quality control to promote high quality treatment for the clinical trials and also for routine clinical practice. This integration of proper and sufficient QA in radiotherapy is an ongoing process, which needs a team of professionals and experts. And in a summary, WHO indicates that a good palliative care program involves interventions at all levels of care, and communication between professionals involved in the care of cancer patients needs to be enhanced to improve coordination of treatment and to improve the knowledge of primary care physician in the role of radiation in palliative care. Further research into more cost-effective treatments and the quality of life benefits from palliative radiotherapy is required in order to have more factual data for treatment indication and applications. Despite the high incidence of cancer, most postgraduate medical school programs provide limited experience in oncology and subspecialty of radiotherapy. And criteria for simulation are not formalized in palliative radiotherapy. In keeping with the goals of palliation, however, simulation and palliative radiotherapy techniques should be simplified to maximize the patient comfort. Simulation or portal imaging is beneficial when treating a spinal cord compression or vertebral metastasis to ensure coverage of involved vertebral bodies. And treatment planning performed after simulation accounts for body shape and ensures adequate dosimetric coverage, including the anterior aspect of the vertebral body. And simulation and/or imaging are important when palliative radiotherapy fields must account for period radiotherapy portals, particularly over the spinal cord and other critical structures. And while simulation is usually a standard of care in high-income and most middle-income countries, it is not always mandatory, especially for the treatment of lying bones like the femur and humerus. And unlike the comprehensive radiation treatment portal using curative therapy, palliative radiation generally only encompasses the tumor value critical to symptoms. Radiation treatment planning must minimize possible toxicities and account for period courses of radiation. Toxicities are reduced by limiting the volume irradiate and through the application of dosimetric principles that reduce integral dose, and the site and volume of involvement are the most important consideration in the development of a palliative radiation treatment plan because of the radiation tolerance of adjusted normal tissues to treatment. And because of normal tissue tolerance to radiation, the total radiation dose that can be administered is low when high doses of radiation are given with each daily fraction. And about a schedule, hypofractionated radiation schedules can range from 2.1 gray per fraction administered over 3 weeks for a total radiation dose of 35 gray to a single 8 gray dose of radiation. In contrast to low daily radiation doses, about 1.8 to 2 gray given with each treatment during conventional radiation schedules to total radiation doses of 50 gray to 60 gray over 5 to 6 weeks, hypofractionation with short oral treatment duration and larger daily radiation fraction is recommended in most palliative radiotherapy applications. And A single large radiation fraction is as effective in relieving pain as other radiation schedules that have more treatment. Overall survival rates for a single fraction of radiation are equivalent to a course of palliative radiation with multiple fractions. Survival is determined by the location and number of sites of metastatic disease rather than the number of radiation fraction used for localized area of disease. And a single 8-gray fraction is generally administered in most European countries and Canada for uncompleted bone metastasis, given the equivalent outcomes in a wide range of randomized clinical trials. And it is interesting to know. Actually, there are 5 reasons why a shorter radiation schedule is advantageous for patients with a poor prognosis. First, it is easier for patients with a poor performance status to complete therapy. Two, or second, response and survival rates are equal for single and multi-fraction therapy at 3 months because median survival is less than 6 months among patients with a poor prognosis and averages around 24 months among patients with metastatic disease. This is important consideration when the number of weeks of survival is evaluated relative to the number of weeks spent receiving palliative treatment. And third, the option of retreatment after a single fraction of radiation may also provide benefit to patients with good prognosis factors as a means to periodically reduce tumor burden and control symptoms. And fourth, a single fraction of radiation is more cost effective. The cost of radiation therapy is reduced by 41% with the use of a single fraction of radiation therapy when compared to a 10 fraction course of palliative radiation. In addition, the cost of radiation therapy is less expensive than the continued cost of analgesics. And fifth, a single dose makes most efficient use of resource and allows more patients to be treated. And we also should consider the metastatic cancer is often treated as a chronic disease, and treatment is given to prevent or relieve symptoms of disease. Re-irradiation for persistent or recurrent pain is often precluded when high radiation doses are administered, but re-irradiation is possible after a single fraction of radiation. And innovative radiotherapy technology and modern imaging capabilities enable the use of stereotactic body radiotherapy to treat patients with metastasis, to optimize tumor control and palliation compared to a standard conventional radiotherapy exists, but there is some limitation for new techniques, especially in low-middle countries, because of shortage resources and time. We can use conventional techniques safely and effectively for more patients, and it would be okay if you face with less resources. Consequently, the shortage of radiotherapy equipment and staff is more severe in low and middle income countries. Worldwide, there is a need for more radiotherapy facilities and upgrading of existing radiotherapy facilities and the training of radiotherapy staff. And as a result, we can say palliative radiotherapy and palliative cancer care should be integrated. Because radiotherapy should be considered for patients receiving treatment for the symptoms of advanced or metastatic cancer. And the symptoms of cancer and its treatment should be controlled throughout the continuum of the course of the disease. And analgesic, including opioids, should be available to optimize pain relief during and after palliative radiation. And since palliative radiotherapy represents an essential part of symptom control, all radiation oncologists should receive training in palliative cancer care. A specific training in palliative cancer care will improve the quality of treatment and strengthen the therapeutic approach. Symptoms of cancer and the adverse effects of therapy should be systematically assessed by radiation oncologists in clinical practice. You know, symptoms of cancer should be systematically monitored and documented before, during, and after treatment. And these patient-related outcomes should be fundamental of clinical radiotherapy practice. And a specific training in palliative care, in palliative radiation oncology is highly recommended within postgraduate education for all physicians involved in palliative cancer care, and continuing medical education in palliative care, including palliative radiotherapy, is essential for all disciplines involved in the care of cancer patients. And expertise in palliative radiotherapy and core evidence-based recommendations for palliative cancer care should be required within postgraduate radiation oncology training programs. And palliative radiotherapy resources should be optimized, because the most efficient planning process and fractionation schedule should be used. And hence, policymakers should ensure access to palliative radiotherapy for all cancer patients is easy, even for patients with advanced symptomatic cancer when there is evidence-based indication such as control of pain, bleeding, dyspnea, and obstruction, and other treatments are not efficient or available. And palliative care should be delivered with minimized treatment burden and financial cost to the patient. And research related to palliative radiotherapy is a high priority, especially in low and middle income countries, since available data mostly comes from high income countries, and different patient populations may require different approaches that can be clarified through research protocols and careful monitoring and evaluation of treatment outcome. And specific programs must be developed for funding of palliative cancer care research. And palliative cancer research should be interdisciplinary. And thank you so much for having me today, and I hope to be healthy and happy everywhere you are.
Thank you so much, ma'am, for this great presentation. Hope you all learned something from this. So if there's any question for ma'am, then please you can put it in the chat box so that she can answer you there. Thank you, ma'am.
Thank you, and thank you for giving me this chance. Good luck.
Thank you so much, ma'am. We were honored to have you here with us today.
Yes.
So
may
I
leave the room and answer to question in chat room?
Sure, ma'am. You can do that.
Thank you.
So moving ahead, I would like to welcome you all again from Neotech. I would like to review the products also again, make you review the products also again of Neotech. So for that, I'll be playing a short video clip for you people. So thank you everyone. Actually, I would like to welcome you all again from Neotech. We already reviewed their products through the video and through the images as well. So I'm sorry I earlier took the name as Nanotech, but the company name is Neotech. And I would like to welcome you all for this conference today. So now, next, I would like to call upon Ms. Sabina Ali. I would like to call Ms. Sabina Ali. She is the academic lead of nursing. Next slide. Ms. Sabina Ali, are you there with us?
Yes, yes.
Yeah, welcome, ma'am.
Thank you. Can you just give me 2 more minutes?
Sure, ma'am. Sure, ma'am.
I'll just take 2 more minutes. That's it.
Sure, ma'am. Until then, I would like to review again the products of Neotech through the images. These are the Neotech products. Can kindly review them from your end. These are the Neotech images, the products that they offer to their company. Kindly go through it. Again, I would like to say that Neotech welcomes you all for today's conference.
Ha, Pratigya.
Ma'am, you are audible. Can you just mute yourself?
Sure, sure.
Audience, I would like to apologize for the delay. Ms. Sabina Ali is facing some technical issue. She will be with us shortly in 2 to 3 minutes. Kindly bear with us.
Hi. Is my screen visible and am I audible?
Ma'am, you are visible. If you are sharing a screen, it's not.
Okay, let me try.
We see you and hear you.
Now
Yeah.
the screen is visible?
Yeah, it's visible, ma'am.
Okay. So again, hello everyone. I am Sabina, registered critical care nurse and working as an academic head of Nursing Next Life. I am more than honored to be the part of this distinctive initiative taken by the Society for Nursing Practice and the Vinayaka Mission Research Foundation. As a person, I always believe that we should never stop learning because life never stopped teaching. And the best example I can quote here is of COVID-19. The pandemic situation has actually showed us all that learning is something which is not only limited to classroom setting, but everyone can have an access to learning from anywhere. With this, I feel so proud to share this information with you all that yes, for nursing professionals as well, we are now having our very own digital learning platform, the next level of learning. Everything which a nursing student, a nursing teacher, or a nursing officer require to enhance their professional growth and development and to expand their knowledge, the body of knowledge, is available on one single platform, which is Nursing Next Live application. Through this application, I actually build a habit of learning something new every day, which gives me confidence and enhance my professional knowledge. If you are a nursing student, then Nursing Next Live application will help the student from day one of their nursing profession by providing them the complete and proper guidance and counseling. Our relationship manager will help the student in identifying the strength and the area of improvement by giving them the progress report, how much progress they are making in their curriculum, the area in which they require more attention, they need to focus more, right? And time to time motivation to all the students, because motivation is something that that keeps us going, right? As a student, if you are a GNM student or a BSc nursing or a post-basic BSc nursing student who want a concept-based learning or who want to make their concept from the very starting, from the first year itself, who want to make their concept more strong, then the Nursing Next Live provide a detailed and comprehensive video lecture series by the top national medical and nursing faculty. Yes, you all heard me right. And let me tell you, these video lecture series will cover all the syllabus, all the revised Indian Nursing Council syllabus. I still remember my BSc nursing student period when I was a student. So the one thing which I really want was just before my semester examination, just before my final semester university examination, we all want the previous year question paper. This is one of the facts for the student life. So the reason why I'm saying that Nursing Next Live application is a one-stop solution for all the nursing professionals, the Nursing Next Live application also provide the solved previous year paper of university semester-wise examination for the top India's university. And along with this, there are n number of options. If you are preparing for your Viva Voice, your interview, and if you need to watch the skill-based procedure videos to enhance your skill and competencies, then also you can refer the Nursing Next Live application. After completing a nursing, if you are someone who are looking for any government competitive nursing officer entrance examination, then again, I am more than happy to say this, that Nursing Next Live application is the top leading digital learning platform, provide the correct quality content for the preparation of state and central government nursing officer entrance examination. And again, I'm very happy to share the result with you all. The recently AIMS NOSET 2021 examination was conducted, and we have scored 500 plus selection in the NOSET 2021, along with the top 2 rank holder as well. Now we have talked about the GNM, BSc nursing, post-basic nursing as well. Then how we can forget about the MSc nursing students? So if you are preparing for MSc entrance examination, and if you have this query or doubt in your mind that which specialty I will select, which specialty I will opt, or how I will prepare myself for higher education in nursing profession, then of course we have exclusive MSc nursing entrance pack available for all the MSc nursing aspirants. So it is like we are having n number of options in Nursing Next Live. As a student, when I was there, so the one thing which I always worried about is time, because time is very precious. If you need the better outcome for your future, all you have to do is you have to utilize your time very wisely. And Nursing Next Life believe that the time which student can opt for is only for their preparation. Let the other work of collecting the quality content, segregating and selecting the best quality content done by the Nursing Next Life top expert faculties, the medical and the nursing faculties. At the end, I would like to say Nursing Next Life provide n number of options to the students if they have any query related to their career, related to their registration process regarding the Indian Nursing Council registration, regarding state registration, and if they have any query related to the scientific subject, then it will be handled by the subject expert through express query segment. Not only this, like I said, that all you have to do is you have to subscribe this Nursing Next Live application through the Play Store. You can join us as a subscriber. You can also collaborate with the Nursing Next Live application as a student reviewer, or you can join us in the scientific review board committee. And one more point at the end, I would like to say, like, if I were in your position, then one thing I would be having in my mind that before investing, we always want to check the quality, which is absolutely right. Yes, before investing in something, we have to go through, we have to check the quality, whether it is appropriate for us or not. So you can also do this we have in Nursing Next Live application a free pack available for all the subscriber by the name of Plan 0. There you can go through the application, go through the content provided in all the other plans of Nursing Next Live. So with this, I would like to thank all of you, and I would like to thank again the Vinayak Mission Research Foundation and the Society for Nursing Practice for giving me this opportunity. And I would like to convey my sincere thanks to all the participants. Again, let me tell you, the time is very precious. If you want a better outcome in your life, then you have to select the right direction and right path. So with this, thank you so much for your future endeavor. Thank you.
Thank you so much, ma'am. You really beautifully explained about the insights of the app and how it will be helpful for the other students, whoever joins and collabs with you. Thank you so much, ma'am. So moving ahead, I would like to take your 2 minutes time, and I would like to thank our academic partners, Vijaya College of Nursing, who helped us conduct today's conference, Convergence 2022. They have given a lot of support for this conference. And we thank Mrs. Vimla A, who is the principal, Mrs. Vijaya Lakshmi, vice principal, Ms. Abhirami, assistant professor, and all the other faculties who have given a lot of support and guidance to make this conference both successful, both physically and virtually. And we are extremely grateful and thankful to them. And we would also like to thank Mrs. Bharti Reddy ma'am, CEO of Vijaya Educational Academy, for her immense support throughout this conference. Thank you. Thanks a lot, ma'am. Thanks a lot, Vijaya College of Nursing. So moving ahead with our next presenter, I would like to call Dr. Kailash Javade. He is transplant surgeon, clinical head, Department of Allied Health Sciences, D.Y. Patil University, India. He is currently the clinical head of D.Y. Patil School of Allied Health Sciences, Navi Mumbai, and has an experience of 23 years in this field. He has completed his MS and has more than 35 publications in international journals. He has also given 25 plus keynote talks, more than 25 keynote talks in national and international conferences. Sir, we welcome you with us today.
Thank you. Can you hear me?
Yes, sir, we can hear you.
So I will start sharing my screen.
Sure, sir.
I will like to thank organizers of Convergence 2022 for giving me this opportunity to share my thoughts on this subject. The topic given to me, can you see the screen? Can you see
sir. Yes, sir.
It's visible.
Yeah, it's visible. It's visible.
Okay, so topic given to me is pre and post-operative care, role and responsibilities of allied healthcare professionals and healthcare people. So this is like odd topic for me, but because there is no literature, there are no guidelines. So what I have done, I have tried to dig out the literature from Google, tried to get what ideas people have put in and what is with my experience, few of the things I have included, and I have made this outline for today's topic. So I will be talking about background and current status, surgery and its classification, care of surgical patient during various phases of surgery, type of manpower involved in patient care, phase-wise manpower requirement, role and responsibilities, and I will briefly talk about special considerations about transplant, and then lastly conclusions. So coming to background and current status. So if we look back last 4 or 5 decades, then the conventional healthcare system is converting and it is becoming a modern day healthcare system. So there is rapid development in past few decades. Computer and information technology has come into healthcare industry a lot. It has become technocratic and multifaceted. Teamwork and quality concerns are become very, very important in healthcare delivery systems. Development of various super specialties and subspecialties has happened in past few decades, and that has made the healthcare put it in a different way altogether. So conventional healthcare system, we involve doctors and staff nurses to offer all healthcare services. Graduates from general sciences, so like BSc Physics, BSc Microbiology, Chemistry. So those people, they used to come into various technical fields and they used to work as a technicians to offer their services. Their number used to remain limited, but if we look at modern picture, last few decades, there is development of various allied healthcare professionals. And last year, government has passed this allied health professional bill, where around 50 courses are incorporated as a allied health professions, and that type of manpower is now will be available in the healthcare delivery systems. They will play an important role in future healthcare delivery system. So coming to surgery and classification of surgery. So if we look at...
sorry to disrupt you in the middle. So you have to start your slide share program. Only then the other screens will be visible to us. Other slides.
So slides are not, you cannot see the slides moving?
So your slides, I can view your screen, but your slides are not moving right now. So there is a small button down. You can press it and start the slide share option.
Just a minute. I will end the show. So can you see now? Is it moving now?
Yes, sir. It's moving now. It's moving now.
Okay, so I will not go into that. When I'm making it a big window, then probably it is not moving. So okay. So this was second slide, background, and then surgery and its classification. So if we look at Oxford Dictionary, they have given a large definition about what is surgery. But for practical purposes, surgery can be defined as any procedure or intervention done by technically competent person for the benefit of individual suffering from an illness. So this is a short and crisp definition of surgery. In surgery, many people are involved. So single person can't perform surgery, entire process alone. They have different roles and responsibilities, and according to phase and type of surgery, need and role of various healthcare professional varies from surgery to surgery. In special situations like kidney and liver transplantation, some specialized management is required. So if we look at the phases, there is a preoperative phase, intraoperative phase, and post-operative phase. Pre-operative phase starts from decision to operate and it ends till the patient comes to operation table. Intraoperative phase starts from taking patient on table till patient shifted back either to recovery or ICU. And post-operative period starts from shifting back to back from operation table till initial recovery and stabilization of the patient. If types of surgery, there is no classification described. Considering various factors, we can group them into different types, like factors like need and urgency of the surgery on the basis of expertise, and based on each factor, we can classify them further. So based on need and urgency, we can classify surgeries as emergency or life-saving surgery, semi-emergency or urgent surgery, required surgery, elective, optional, and daycare surgery. Based on the expertise, we classify it as a broad specialty like general surgery, gynecology, trauma, orthopedics, ENT, general ophthalmic surgeries, and super specialty like oncosurgery, urology, neurosurgery, plastic surgery, pediatric surgery, joint replacement, and transplant surgery. There are certain specialized surgeries where specialized requirement is there, technical as well as specialized training is required, like laparoscopic surgery and robotic surgery. So care of surgical patient during various phases. In preoperative phase, this phase starts, as I already told, it starts from time of decision to operate and end with transfer of the patient to operation table. Various things are involved in this phase. Most important is preoperative evaluation and workup of the patient, patient preparation for the surgery, taking consent, management of logistics, collection of all records, and finally the shifting of patient to operation table. Preoperative evaluation and workup, it is done either on OPD basis or after admission to the hospital. Complete history taking and clinical evaluation is required both by clinicians as well as by nursing staff and allied health professionals. Assessment of comorbidities, routine laboratory and radiological investigations, special tests, pre-anesthesia evaluation, patient and family counseling, and most important is we have to discuss about financial aspects of the surgery. Next is a patient preparation. So patient preparation starts from admission in the hospital. Usually there are standard protocols and checklists available for preparing patient for the surgery. Charting and filing of the file is very important in this phase. Special consideration about certain medicines like anticoagulants, antihypertensives, it is important. Special preoperative preparation is required in some conditions like bowel preparation in abdominal surgery, pre-transplant dialysis. So all these things are important. Then next important thing is site marking and site preparation. So this is also part of patient preparation. Then comes the consent. Consent, we have to take different types of consent. Consent for surgery, consent for anesthesia. Sometimes cases are high risk, so then we have to take high risk consent. Consent for blood and blood product usage. Sometimes we have to take consent for photography and research records, and sometimes we require to take special consideration, special consent as in case of amputation and as in case of transplantation. So apart from this, other aspects are important like theater booking, reservation of blood and blood products, arrangement of special gadgets and implants, insurance related matters. So when we think about the surgery, so many things we have to do. That's why a lot of manpower requirement is there. Then comes the intraoperative phase. Intraoperative phase it starts from shifting patient to operation room and ends after shifting patient back to recovery room or intensive care unit. This is the most important phase and many complications can happen during this phase. So coordination is important task in this particular phase. Apart from main thing happens on table, many things are happening out in the surrounding. So one needs to be coordinated during this particular phase of surgery. So in intraoperative phase of surgery, first comes is a preparation of anesthesia trolley. So based on the type of anesthesia, we have to prepare the trolley. Anesthesia technicians, they play this role. OT arrangements. So again, operation theater technologies, they play the role in arrangements like arrangement of energy resources, operation table, its positioning, patient positioning, arrangement of technical gadgets, instrument trolleys, and monitors. So nowadays, all these things are very, very important. Special events like induction of anesthesia, taking patient out of anesthesia, and in case of transplantation, reperfusion, these are special events where lot of things happen in the physiology of the patient and around the patient. So a lot of manpower is required during this particular phase. There are certain intraoperative requirements like blood and blood product requirements, surgical material, and special equipment required during the surgery. So coordination is most important. If everything is coordinated, then there is no panic situation and surgery goes on very smoothly. Post-operative period starts from shifting patient back to recovery or ICU and continues till patient gets stabilized. Regular monitoring is key thing in this particular phase. There are important tasks to play like maintain the airway, monitor the vitals, assess effect of the anesthesia, management of pain. We have to promote recovery with the help of, we have to offer physiotherapy, we have to do nebulization, so many things are involved. And then we have to plan the initial discharge plan. So till that, we have to work continuously for the patient in perioperative period. So why teamwork and continuity of care? Excellent surgical outcome is result of good teamwork, but it doesn't stop at that level. So teams are required because for the upgradation of medical care, evaluation of outcome by proper clinical research, and facing litigation in some of the situation. So entire team is responsible for doing so many things like technical aspects are there, clinical aspects are there, and documentation is most important thing in this. So appropriate documentation and record keeping is the most important aspect. So coming to type of manpower involved in the patient care, particularly surgical patient care. So various types of manpower is involved in the offering the services. Doctors are key people like consultant, resident medical officer, house officer. Then nurses have important role. They can be A&M, GNM, BSc nursing graduates, postgraduate nursing nurses are available. Then allied health professional, this is something which I am going to talk in detail. And then there is a role of administrators like managers, marketing, billing, analysts. So many people are involved in management of health, these patients. Coming to manpower in pre-operative phase. Now in pre-operative phase, main role is doctors, nurses, physician associate or assistants. They also play, they are playing important role in this particular phase. Apart from that, lab technicians, radio imaging technicians, anesthesia technicians, they also have to play important role. During intraoperative phase, doctors, apart from doctors and nurses, anesthesia and operation theater technicians are involved. CSSD technicians are involved, physician associates are involved, perfusionists are involved in some important cases like cardiac cases, sometimes even in transplant patient, we have to keep patient on heart-lung machine. So perfusionists are involved, and sometimes there is intraoperative patient assessment has to be done with biochemistry parameters like doing ABG, intraoperative EBG, doing TEG. So lab technicians are also involved. So various types of manpower is involved in intraoperative phase. Similarly, in postoperative phase, apart from doctors and nurses, physician associate have some role, physiotherapists, occupational therapists, and dietitians, they play important role in patient recovery. So coming to the roles and responsibilities of various types of team members in the surgery. So senior consultant or specialist, they are the in charge of the patient. Say they see the patient at specific time. Overall planning and patient management is done under the supervision of senior consultant. Then comes the role of registrar. Registrar is the senior doctor who is there to supervise the resident and interns. Residents are trainee doctors, particularly in teaching institute. They are there. So trainee in specialized subject. They look after patient care. Day-to-day activities are done. So residents are considered as backbone of healthcare delivery. Through them, training, the healthcare is delivered to in the academic institute. Interns, they have completed the academic studies and they are supportive. Their role is usually supportive in nature. And at some places, students also, majority of the time they are observer, but sometimes student doctors is a concept given in the literature, and they also participate in healthcare delivery in some or other way. Nurses have very important role. Like doctors, nurses have different roles and responsibilities based on their experience and specialties. Nurse unit manager or nurse in charge, they are the in charge for particular thing. Like OT in charge is the in charge for entire overall management. Associate nurse unit manager, she is basically helping in charge in doing her activities, and whenever in charge is not there, she takes a role of in charge. Now, nurse practitioner, these are highly skilled nurses with an advanced level of training. India has got such type of trained nurses, but unfortunately, there is no special designation as a nurse practitioner. That's why our nurses are not working as a nurse practitioner. Specialist nurse, again, this is a Western concept where nurses are specialized in different aspects, and they work as a clinical nurse consultant, clinical nurse educator, triage nurse, emergency department nurse. So this is a different concept which is there in Western country. Registered nurses provide high level of day-to-day care, perform some minor procedures also. Enrolled nurses provide basic medical care under the supervision of senior nurses. In India, this scenario is somewhat different. Clinical nursing is unfortunately decreasing in India because there is a lot of documentation which is done by nurses in India. So role is becoming administrative and clerical to maintain the documentation, to help the administrators. Nurses are playing very, very important role. Of course, that role is also important, but because of that, their clinical role is going down. So that is something that is creating a gap in the healthcare system in India. And that's where the role of allied health professionals is coming into picture. So allied health professionals are university educated practitioners who work as a part of multidisciplinary healthcare team. They are involved in assessment, diagnosis, and treatment of the patient. They work to prevent diseases and disabilities. In India, as per Allied Health Professional Bill 2021, around 50 types of professions are involved, and they are indexed in the indexed as allied health professions, and such kind of manpower will be created and will be appointed in various healthcare institutions in future. So allied health professionals in pre-operative phase, physician associates, they play very important role. Under the guidance of treating faculty, they can do initial assessment, they can be involved in collecting lab reports, take references, inform it to consultants. They can also participate in counseling and transfer of the patient to operation theater. Next, allied health professionals, important professionals are radio imaging technicians and lab technicians. They are involved into pre-operative assessment and diagnosis of the patient's condition. In operation theater, anesthesia technicians and operation theater technicians, they are involved. Anesthesia technicians, basically they do pre-operative assessment and preparation of the patient for the anesthesia. They are also involved in preparing trolley. So intraoperative role, physician associate, again they play very important role. They can assist surgeon in all surgeries, patient positioning, closure of the abdomen. So all these type of tasks they can perform. They are well acquainted with all these skills, and they are very supportive. And at Vijaya Patil, we have started this program, and we found they are very useful manpower in the healthcare industry. Anesthesia and operation theater technician, they support the anesthetist, and also they are involved in overall management as well as doing troubleshooting during the procedure. CSSD technicians, they have important role to maintain the asepsis and sterility, which is a very important part in surgery. Lab technicians, again I have told, intraoperative investigations like ABG, TEG, it is done by the lab technicians, and many times they are sitting beside the operation table to perform these procedures. In post-operative phase, again, physician associate, they work with surgical team very closely and involved in all type of care. Lab and radio imaging technicians, they are involved in care of the patient to provide diagnostic support. Physiotherapists provide support for patient's recovery. Occupational therapy, they also provide necessary support. Dietitian play a very important role to build the patient nutritionally and help him in the recovery. So these are roles and responsibilities of various types of manpower. Now coming to special consideration about transplant. So transplant is a science of replacing diseased body parts, organs, tissues or cells with healthier ones obtained from the donor. So this is a transplantation. So various types of transplantations are done. Common is kidney transplantation. Next common is liver transplantation. Heart transplantation is now done at many centers in India. Pancreatic transplantation, though not done commonly, it is picking up in India. So transplantation has some special considerations. Since I am personally involved into transplantation, I would like to talk about special considerations which are there. So transplant involves brain-dead declaration, counseling, retrieval, transportation, and transplantation of the organs. So these are special situations. Again, various types of manpower is required. In living donor cases, there is a lot of medical legal documentation. Proving the relation is important task. Donor-related complications are there. Meticulous preoperative assessment is required. Of course, all the things are done by clinicians, but there are so many, at many transplant centers, nurse play the role of transplant coordinator. There are social workers, they are involved. And now physician associates, they are also taking lead in all this assessment. In preoperative phase, patients are usually very sick, various comorbidities. They need to optimize before taking patient on the table. In the intraoperative phase, lot of monitoring is required, particularly warm and cold ischemia, which is related to organs. The organ like kidney, which we remove, there is something called as warm ischemia. So kidney can get damaged with warm ischemia. More graft dysfunction can happen. So we need to manage all these things. Perfusion and immediate outcome is very important during intraoperative phase. So intraoperatively, we have to restart the circulation, and that particular phase is very important. So post-operative phase, patients are started on immunosuppression medication. So their immunity is decreased. So that's why they need special requirement. They need to monitor. Rejection is another. The organ like kidney, which we put inside the body. So body tries to reject that kidney. So that is an important problem, and we should be vigilant to identify whether patient is developing rejection, and we need to monitor it. Drug levels are also important, and long-term care plan in transplant patient is very important, where there is a role of regular communication and follow-up. And last important thing in transplant is prevention of chronic rejection. So all these things require regular monitoring of the patient, continuous communication with the patient, which is not possible for single doctor to do all these things. And there is a role of allied health professionals. They are playing very, very important role, particularly physician associates are playing important role in care of transplant patient. So this is all about the perioperative role of all various types of healthcare professional, particularly allied health professional. So coming to the conclusion, modern day healthcare is evolved around the technology. That's why it is a bit complicated. It requires team. In surgery, surgeons are becoming the masters of medical orchestra because they have to manage entire team to provide the optimum care and deliver good outcomes. So ultimately, they are the in charge. That's why they need to manage, apart from technical aspect, they need to do this manpower management as well. Role and responsibilities of nurse has been changing, and they are involved more into administrative aspect of patient care. So nursing role is changing, but still at some places. Recently, I visited ICAHS ITS Ahmedabad, where ICAHS is Institute of Kidney Diseases and Research Center. It's a huge hospital located in Ahmedabad, catering services to kidney transplant patients in entire Gujarat and surrounding states. And I found that the nurses are playing very important role. In fact, the laparoscopic donor nephrectomy, the nurses are very good. They know all the protocols. But at some places, like in various corporate hospitals, I am seeing they are majority of the time they are involved into documentation, JCI related documentation, NABH related documentation, and the entire thing is put on them. So allied health professionals are the new champions who need to get appropriate skills. So now there is a lot of allied health professional coming up. So actually, one of the issue in this field is there are 3 months crash courses, 6 months programs, 2 years diploma program, 1 year certificate course. So there is no standardization of the teaching these allied health professionals. So although they are new champions, they need to be properly skilled and they need to be trained properly to so that they can bridge the gap in current healthcare system, and they can become very important people in the entire healthcare system. They have larger responsibility to play in healthcare system by contributing medical documentation, clinical research. So this is something which I feel we Indians are lacking. We are very poor in documentation and clinical research. That's why we have very big numbers, but unfortunately our research, when it comes to research, our documentation is less and our research papers are less. So I think allied health professionals, they have to come and they have to bridge this gap as well. Allied health courses are still under evaluation, and training them properly will help them becoming a backbone of healthcare system and contribute more to the medical field in future. So this is all about role and responsibility of healthcare professional. So I will stop here. If anybody has any question or query, I am free to answer it.
Thank you so much, sir. I think this was very helpful for all of us. If there is any question for Kailash, sir, then you can please put your questions in the chat box. He will be happy to answer you. Thank you so much, sir. Thank you for your time. Thank you, sir. So before moving ahead with our next presenter, I would like to express my gratitude to Vijaya Educational Academy Chennai, who helped us in making this conference, Convergence 2022, a great success. So thank you, Vijaya Educational Academy Chennai, for your immense support. So now it's time for our next presenter. Before that, I would like to introduce our next presenter and also play a short video for you people. So our next presenter is Dr. Gozika Esther Izini, Professor, University of West Indies from West Indies. She is a committed lecturer with over 10 years of experience in different academic institutions and has an experience of teaching students from various social and cultural backgrounds. She completed her bachelor's from, she took her degree of Doctors of Optometry from the year 2000 to 2006 from Abia State University, Uturu, Nigeria. She completed her master's in optometry from 2016 to 2018 from University of KwaZulu-Natal, South Africa. She served as a lecturer in University of Gondar, Ethiopia from January 2009 till July 2011. She also served as a lecturer from December 2012, from February 2012 to December 2016 in Madonna University, Elili, Nigeria. Currently, she is working as a lecturer in University of West Indies St. Augustine campus from January 2018. Before we move ahead, I would like to play a short video. Kindly give me 2 minutes. I'm just facing a technical issue. The video will play shortly. I hope my screen is visible right now. I'm playing the video for you people. Hello? Yes, sir. I'm sorry I had to stop sharing the video as there was some technical audio issue. Kindly give me 2 to 3 minutes time so that I can play it again. And the audio will be like everybody can hear the audio then. Hello everyone, hello again. Sorry for the technical issue we were facing. I would like to share the screen again. So our keynote speaker has sent us a video of her slides and she has well explained about it. So I hope it helps you all.
collaborate with different healthcare professionals in different ways. For example, an eye care professional can collaborate with neurologists and occupational therapists in the management of patients with concussion, traumatic brain injuries, low vision. You know, when people have concussion or traumatic brain injuries, they usually have severe visual impairment. So in that case, they can work with ophthalmologists who are mostly something like behavioral optometries in order to do some vision therapy, which can help them to regain their sight and be able to move about their daily activities. They can also collaborate with medical doctors. How can they do that? Medical doctors and optometrists usually see more patients sometimes. And some patients, when they come to the clinic, they might be having problems that are not associated with the eye, but they have effect on the eye. Something like hypertension, diabetes, cholesterol. When you have them, they could affect the eye. So the patient could come to an eye clinic, and in collaboration, the optometry will be able to measure the blood pressure and be able to advise the patient to go to a medical doctor or a physician to be treated. In other words, a medical doctor can also direct or refer patients who are hypertensive or diabetic to optometry clinic because they know that hypertension, diabetes, they have ocular manifestations, meaning that they affect the eye. So when you have diabetes for some time, it could lead to diabetic retinopathy, which could cause severe vision impairment. So if a diabetic patient does not manage or control the sugar level, well, it could end up going blind. So that's why diabetic patients are always advised to register with an eye clinic once they are diagnosed with diabetes, especially if they have been diagnosed with diabetes for over 5 years. They can also collaborate with pediatricians. So sometimes optometrists or pediatricians will see children with learning disabilities, eye and vision problems, neuropsychological conditions, behavioral issues, or ocular motility disorder. They can refer them to eye care professionals who will help to treat them. For example, children with learning disability, they will be able to distinguish those ones with learning disabilities and those ones with eye problems. So some of them might have eye problems as a problem, while some will have learning disability. So vision therapists can train children with learning disabilities to help them improve, as well as those ones with behavioral issues. And those ones with ocular motility can also be directed to orthoptics for vision therapy. Eye care professionals can also collaborate with nutritionists in management of diabetic retinopathy. We know that diabetic retinopathy develops as a result of over a prolonged, uncontrolled sugar. So when a patient has diabetes, it's expected that the sugar level in the blood is high. So if it is not well controlled, it will lead to diabetic retinopathy. So that's why they can work together with a nutritionist to advise on the nutrition, and also for people with vitamin A deficiency who could be having night blindness, we'll also advise them on what to take in order to get vitamin A, or those with age-related macular degeneration, dry eye syndrome, myopia, hypercholesterol, and hypertension. Again, eye care professionals can also collaborate with social workers. So social workers can help patients who are blind or severely visually impaired to get resources. Resources, for example, in getting transportation for their medical appointment, follow up with their medical advice, get a self-care in terms of education, school-based intervention, family intervention, or some of them were involved in a situation where they are being neglected or abused. IK professionals can also collaborate with health informatics. Health informatics should help in providing data or in providing patients information. They should make patients information easily accessible for these healthcare professionals so that patients can be treated on time, because some of these conditions, if things are not done on time, it will lead to a lot of consequences. So they can also provide some information that will be relevant for public health. Eye care professionals can also collaborate with occupational therapists in terms of children with special needs, autism, and attention problems. They can also collaborate with psychologists, clinical psychologists in the management of people who suddenly go blind, or patients with visual impairment, or blind patients. Barriers to collaborations. So some of the barriers to collaborations are lack of finance on the side of patients, little or no feedback. So sometimes when you refer patients to see another healthcare professional, you don't get any feedback from them. Or some of them, there's a difficulty in scheduling appointments for the patients. Some of them don't even know how to collaborate or not sharing information because they feel that they don't have to share information to this healthcare professional because they feel they know more than that healthcare professional. Some of them are also scared of losing their patient to another healthcare provider or another healthcare professional. It could also be superiority. So sometimes some professionals feel that they are superior to others. So when they feel they are superior to others, they won't like to collaborate with them. How to overcome these barriers? So in order to overcome these barriers, the health informatics on their own side should make medical records accessible and available to healthcare professionals. There should be an improvement on eye care providers' communication and feedback, especially when patients are referred to them. They should always try to write a referral feedback so that those ones referring patients to them will be well updated or will be well informed. They should always consider referral as a part of patient care. So when you refer patients, you're not only helping that patient, you're also helping your profession. There are useful strategies in order to foster collaboration. One is to be committed to finding ways to collaborate. Okay, being patient focused. So when you have a patient in mind, as the major person who is involved here, you always try to do anything possible in order to make sure that your patient is comfortable. They should value interprofessional and continuing education. So not because you're a nurse or you're a doctor or whatever, you have to try to know what do this other profession do, so that when you have that information, it will help you to have trust when you refer. They should develop patient and public education and also be open to new technologies and ways of communication. In conclusion, collaboration benefits healthcare providers and patients. Every allied healthcare provider is unique, and with collaboration, patient safety is ensured. In order for us to succeed in the reduction of prevalence of visual impairment and blindness, healthcare workers should collaborate as a large team and follow the theme, we are stronger and better together. So with this, I say, thank you very much for listening.
Thank you, everybody, for patiently listening to Dr. Nagosika's presentation. I'm very sorry for the technical issue that we faced, that I was not able to provide you with the audio of the presentation. So this makes us come to an end of today's conference. So now we'll be concluding the conference. Give me 2 minutes, please. I really hope you all enjoyed the conference that was held, Convergence 2022. Thank you all for being a part of it. I thank each and everybody for being a part of this conference, especially the keynote speakers who actually gave their valuable time to us, and we could proceed with our conference because of them. They gave a really good and insightful presentation and really informative presentation. So I would like to extend a very hearty vote of thanks to all the keynote speakers who actually took out time from their busy schedule, graced this occasion, and gave us a very great insight on various topics with their speech. I would also like to thank Vijaya Educational Academy again, along with Vijaya College of Nursing and Dharan Institute of Health Sciences, who actually supported and guided us, because of which we were able to make this program a huge success. Along with that, I would like to thank our sponsors, and along with that, I would like to thank our partners, Neotech, CBS, publishers, and 2Fitness. Thank you all for being a part of this conference, most importantly, because you were the patient listeners, and I hope we could provide you with great information through this conference. Thank you, and kindly join with us again in future. Thank you so much, everyone.